Welcome to the third meeting of the Joint Interim Standing Committee on Health and Human Services. We're going to go ahead and call the roll first. For those members attending virtually, would you please turn on your cameras and respond when you hear your name? Ms. Rowe, please call the roll.
Senator Hardy.
Here.
Senator Harris.
Present.
Senator Spearman for Senator Danyate.
Here.
Assemblywoman Gorlow.
Here.
Assemblyman Hafen. Assemblyman Orrin Licker.
Here.
Assemblywoman Titus.
Here.
And Chair Peters.
And I am here. Please go ahead and mark Assemblyman Hafen when he arrives as present. I believe he was just running a few minutes late. Before we get started with public comment, I want to just take a moment for us to have some silence for the folks in the Ukraine who are dealing with the atrocities to their country, and think on them for just a minute, if we would, please. Thank you so much. We do have a full agenda today, and I am a little bit jet lagged. I just flew in from the East Coast last night, so please bear with us as we make it through this agenda today. This particular area of focus in our agenda today can be very personal to folks, and I appreciate the emotions that come up from the discussion. This is a heavy issue, and I want to respect what comes up for us in this area. So please let me know if you need to step away at any point. Depending on the time we need for the first part of the agenda, we are planning to take a lunch break around noon, and I believe that there should be lunch available for you down in Grant Sawyer, and we have lunch available up here for me and staff. I didn't miss public comment, right? We're going? Okay. I'm going to go over some housekeeping. We're doing a little bit of a different forum here today with 3 different locations. So just to keep things clean, I want to remind folks, please silence all of your electronic devices, especially cell phones and laptops during the meeting. For members joining online, please also mute your microphones when you are not speaking, but leave your camera on so we can ensure we're maintaining a quorum and know who's present at all times. Additionally, I ask our presenters on the Zoom video call to leave your cameras off and microphones muted until I call up the agenda item under which you are presenting, or I will direct any questions to you. The Zoom call has a chat feature. However, this feature is only to be used for technical assistance. Any links or information that you would like to share during your presentation should be stated verbally on the record, and those links can also be sent to staff to disseminate among us. Agenda items may be taken in a different order than listed. 2 or more agenda items may be combined for consideration. An item may be removed from the agenda, and discussion of any item on this agenda may be delayed at any time. The committee's meeting material can be found on the Nevada Legislature's website. You can also sign up for electronic notifications related to any activity on the committee's website. If you wish to testify in person, please sign in at the table by the door and leave a business card. If you do not testify, you may also want to sign in so there's a record of who is interested in this particular topic, and in the event the committee needs to contact you later. When testifying in person, please turn the microphone on to speak and off to listen. We have listeners and viewers in Las Vegas and online. We are recording this meeting, and it will be available on the legislature's website. We will have a public comment period at the beginning and end of the meeting. Public comment is limited to 3 minutes per speaker. In addition to testifying in person, members of the public may provide public comment in 4 different ways, all of which are listed on the agenda. You can provide public comment by calling 669-900-6833 and enter meeting ID number 895-2582-3482 and then press the pound sign. When prompted for a participant ID, please press pound again. You may email your comments to the committee's email address. You may also mail written comments to the research division, and we still retain a fax if you would like to send in your comments by fax. You can find the phone number and fax numbers, email addresses, and mailing addresses on the agenda and the committee's website. With that, we'll go ahead and move on to public comment. Public comment will be limited to 3 minutes per speaker. Staff will time each speaker during public comment to ensure everyone has a fair opportunity to speak. We also ask that you do not repeat what a previous commenter stated. An additional opportunity to make public comment will be available at the end of the meeting. We will start the public comment from those in the physical locations and then move to public comment from anyone who has called in. Is there anyone in Carson City who would like to provide public comment at this time? Seeing none, we'll move on to Las Vegas. Is there anyone in Las Vegas who would like to provide public comment at this time? I see someone approaching the dais. Please state your name for the record and you may begin.
Good morning. My name is Char Frost, Charfrost. I am so grateful that you are taking up this very important topic today. I'm the Statewide Family Network Director for Nevada PEP and a Certified Family Peer Specialist. Nevada PEP is the statewide family network designated by SAMHSA to support families of children and youth with mental health care needs. We also sponsor Youth Move Nevada, who was named Chapter of the Year by Youth Move National and continues to be recognized nationally for their outstanding youth-developed podcasts focusing on mental health recovery. Nevada PEP has served as the parent partner to DCFS in all 4 of the Nevada System of Care grants since 1998. Nevada PEP has also provided family peer support to families across Nevada for over 24 years. Our family peer support providers are nationally certified, and last year, Nevada PEP supported 2,786 families in Clark County, 399 rural communities, and 563 in Washoe County, with 377 referrals directly from the Mobile Crisis Response Team and 262 from the Harbor programs in Clark County. We have served as the parent and youth voice on rural Washoe, Clark, and the state consortium, as well as other planning bodies to improve systems that serve children and youth with mental health care needs, and we are committed to continue being part of the solution for Nevada's children and families. And the other thing I wanted to mention is that we do all of this work from lived experience. I am the mother of 2 young men who grew up here in Nevada who both have behavioral and healthcare and mental health care needs. And we just continue to support families to ensure that they have somebody who has walked that walk and can walk alongside them to support them in whatever way they need. So thank you very much.
Thank you, Ms. Frost. It's great to see some familiar faces. Are there additional folks in Las Vegas who would like to come up for public comment? I am not seeing anybody approach the dais, in which case we will move on to our virtual or call-in public comment. Broadcast and Production Services, or BPS staff, will interact with those making public comment to facilitate participation in the meetings. BPS, please add the first caller with public comment to the meeting.
Thank you, Chair Peters. To provide public comment, please press *9 on your telephone to take your place in the queue. Caller, you're unmuted. Please begin.
Thank you. My name is Leanne McAllister, Leann McAllister. I am the Executive Director of the Nevada chapter of the American Academy of Pediatrics. In October of last year, the American Academy of Pediatrics, along with the American Academy of Child and Adolescent Psychiatry and the Children's Hospital Association, declared a national emergency in children's mental health, citing the serious toll of the COVID-19 pandemic on top of existing challenges. The declaration called on federal and state governments to address the issue through several actions, including improved access to telemedicine, improving effective models of school-based mental health care, accelerating the integration of mental health care in primary care pediatrics, and strengthening efforts to reduce the risk of youth suicide. Today, you will hear several policy suggestions, many of which pediatricians at the Nevada AAP support. Through me, my members are asking that you prioritize three in particular: later school start times, stronger gun laws, and state support for the pediatric access line. I've detailed all three in my written submitted public comment earlier today. The Nevada AAP currently has 280 members, most of whom are board-certified pediatricians, both primary and specialty care. Members also include pediatric nurse practitioners, physician assistants, pediatric residents, and medical students, all of whom live and work in Nevada and have dedicated their professional lives to the health of all children. Thank you.
Thank you, Ms. McAllister. Is there anybody else on public comment line, BPS?
Thank you, Chair Peters. The public line is open and working. However, there are no additional callers at this time.
Thank you very much. Just want to remind the public that there will be an additional opportunity for public comment at the end of the meeting. We will go ahead and move on to close public comment and move on to agenda item 3, approval of meeting minutes for the meeting on January 20th, 2022. Now, these meeting minutes are substantial. They are verbatim minutes, and staff has reviewed them multiple times for accuracy and content. Members of the committee, are there any questions regarding the minutes?
Move to approve.
Madam Chair, I read the minutes and I would move to approve.
Oh, thank you so much. Seeing no other questions, Senator Hardy has moved to approve the minutes. Is there a second?
Second.
I'll second.
I believe that was Assemblywoman Titus. Thank you so much for the second. All in favor, please go ahead and say aye. And for those on virtual, I will I will let you go second to Las Vegas. We'll start in Vegas. All those in favor, say aye.
Aye.
All those on virtual, please say aye if you're in favor.
Aye.
Thank you so much. Any opposed in Las Vegas? Any opposed virtual? Motion carries unanimously. Thank you so much. Oh, although I did not hear Senator Spearman. Do we have Senator Spearman?
Yes, I said aye and I also raised my hand.
Oh, great. Okay, thank you so much.
Yeah. I'm having some internet issues. That's why my camera's off right now, but I am here.
Perfect. Thank you so much, Senator, for joining us today. With that, the motion carries, and we will go ahead and move on to agenda item 4, which is a consideration of regulations proposed or adopted by certain licensing boards pursuant to NRS 439B225. Eric Robbins, our Principal Deputy Legislative Counsel for our committee, will go ahead and review these proposed regulations.
Yes, Eric Robbins from the Legal Division of LCB. So as a reminder, pursuant to NRS 439B.225, the committee has the responsibility of reviewing certain regulations proposed by healthcare licensing boards. As a reminder, the committee does not take any formal action on the regulations, but can ask questions of the agency personnel from the agencies and boards that adopted the regulations. There are 5 regulations on the agenda today. R040-21 from the State Board of Pharmacy, R067-21 from the Board of Environmental Health Specialists, R076-21 of the Board of Occupational Therapy, R118-21 of the Board of Medical Examiners, and R126-21 from the State Board of Health. The first three of those regulations, R040-21, R067-21, and R076-21, have all been adopted by the agencies and are awaiting final hearing by the Legislative Commission. So they will be heard at the next meeting of the Legislative Commission, which has not yet been scheduled. The last two regulations, R118-21 and R126-21, have not yet been adopted, and they will still have hearings with the adopting or the proposing agencies. And so since we have a few regulations today, I thought I might ask the members which regulations they have questions about, and then we can go forward and call up the relevant agency personnel in order. So anyway, which regulations do members have questions about?
Thank you, Mr. Robbins. Are there any questions from the committee regarding these regulations?
Madam Chairwoman?
I believe that is Assemblywoman
Dr.
Titus.
Right.
Go ahead.
So thank you. I just want to make a comment. We don't really have to have them come up, but I want to acknowledge the State Board of Pharmacy's regulation where they're changing the terminology in Section 1 to using the term reciprocity without having to show the actual documentation. So I appreciate that. I think that we need this access to care and some of the stuff that we're doing is so important by expanding this process of licensure to expedite it. So thank you to the Board of Pharmacy.
Absolutely agree wholeheartedly, Dr. Titus. Are there any other questions from the committee related to these regulations? Seeing none, I believe we can move on to the next agenda item, which begins our presentations. Agenda item 5 is an overview of Nevada's children's mental and behavioral health surveillance data. I just want to thank staff for the suggestion of starting with the data first before we dive into the discussion of actions on the ground and potential actions in the future. Today we have Dr. Megan Freeman and Samantha Cohen to go ahead with this presentation. I believe we have both of them online virtually, and I would ask them to please proceed when you're ready.
Dr. Megan Freeman, for the record, thank you so much, Chair Peters. Samantha, if we can just put those slides up. Thank you. Again, Dr. Megan Freeman, for the record, thank you so much for having me here today on this agenda and this particular agenda item as well. As the State Children's Behavioral Health Authority, I am thrilled that we will spend most of today discussing the needs of children and families. Next slide. I'd like to talk today a little bit about the national context surrounding children's behavioral health before I move into the data. I agree we need to use data as the foundation, and I have a few other thoughts to go over before we move into that. Next slide. So I did want to start the day today by taking a step back and reflecting on stigma. I think it's important for us as a society to look at the role stigma has played in shaping our behavioral health system into what it is today. Stigma, of course, is formally defined as a negative attitude or discrimination towards a person or a group because of a distinguishing characteristic. In this case, it would be mental illness or behavioral health need. So in increasing awareness and improving understanding about the struggles and the needs of those living with behavioral health conditions, we are working to break down that stigma and reinforce the idea that behavioral health is a critical piece of overall wellness. So this slide is about violent behaviors, which of course this is a theme that comes up in the media pretty frequently about folks with mental or behavioral health needs. Next slide. In fact, the great majority of individuals suffering with mental or behavioral health illness are no more likely to be violent than anyone else. Next slide. Statistically, a number of us in this room or on Zoom at the meeting today either struggle with our own behavioral health or we're supporting a loved one who does, but very few of us here would probably be willing to stand up and identify ourselves as such in a public forum. Next slide. But 87% of Americans agree that having a mental health disorder is nothing to be ashamed of. So why are we so reluctant to share this information with others if it's what we believe? So the goal for those of us working in the behavioral health space is for it to be as acceptable to seek treatment for a mental or behavioral health need as it is to tell your friends or your boss that you went to the doctor to get your thyroid checked or because you sprained your ankle. Next slide. To set the stage for many of the conversations today, I wanted to also draw attention to this statistic on childhood trauma. How many children in the general population do you think have experienced at least one traumatic event by the time they are a teenager? Next slide. The answer is more than 2/3. Childhood trauma places a person at risk for a number of negative outcomes, not only as children, but also as an adult. So this includes chronic health conditions as well as premature death. And these are public health level exposure statistics, outcomes, and prevention opportunities. So we need to provide trauma-informed care as the exception and not the rule. Sorry, as the rule and not the exception. Next slide. So this is my last thought slide for the day. You might already think about this a lot, but I'm going to pause for just a moment to give everyone a minute to reflect on this intentionally this morning. Who haven't you seen in a long time that you miss because of the pandemic? What routines were disrupted that you never had a chance to pick back up? What life events or milestones did you or your children miss out on? And do you feel that anything good has come into your life or there have been any positive changes, either personally for you or for our society because of the pandemic? Next slide, please. So I asked you to reflect on your pandemic experience, partially because I think it's important for all of us to do that from time to time, and partially because it's impossible to talk about behavioral health or wellness right now without acknowledging the impact of the pandemic. The pandemic has had a ripple effect across systems where we all have our own individual experience of the pandemic and we're coping with our own struggles related to that. And then we all live within multiple systems that have also been impacted. So for most people, that includes a family system, your employer, a system of healthcare providers that you depend on to keep you healthy and functioning at your best, and a support system of friends and acquaintances that you rely on for social support. And almost everyone I know has experienced disruptions in all of these systems. So think about that for yourself as an adult. And then for children, the impact has been magnified because outside their family system, the biggest system they rely on to ensure they're keeping on track with healthy development is their school system, or if they're a young child, a child care provider. They experienced sudden disruptions in these systems, as well as in many cases, sudden isolation from extended family or caregivers they relied on, like grandparents or regular babysitter or nanny. And at the same time, their parents or caregivers were likely experiencing one or many pandemic-related stressors like financial instability, food insecurity, housing instability. They may have been working from home. There were school and childcare center closures that were very obviously widespread. And then, of course, there was illness. Many parents and caregivers are frontline workers, so they're at greater risk of COVID-19 as well as burnout. And nearly 2,200 children in Nevada have lost a parent or caregiver to COVID-19. So whereas typically in a disaster or emergency, we would move through a series of relatively well-defined coping stages from initial impact through response and recovery. There's fairly well understood emotional reactions and milestones at each phase for an individual and for a community. The COVID-19 pandemic has been more of a circular experience. So every time we think we've made our way through a phase, something else happens. There's a new variant or something, and the whole thing starts over. So this has impaired psychological recovery for many of us, including our children. So although we may have created a new normal, the continued impact prevents us from fully moving on past uncertainty, fear, exhaustion, loneliness, depression, and loss of control. Next slide. Since April 2020, the CDC has been conducting a weekly survey in collaboration with the U.S. Census Bureau and other federal agencies. It's called the Household Pulse Survey. Excuse me. The goal of the survey is to produce near real-time data on the social and economic effects of COVID-19. So the recent data from the CDC, the most recent data I could get was the week of January 26th through February 7th of this year. That data demonstrates that Nevadans are not doing okay. We are ranked 4th in the nation, and 37% of adults are reporting symptoms of anxiety or depression. So that's more than 1 in 3. And ranking 4th in this case is not a good thing. So check on your friends, check on your neighbors, your family, check in with yourself. It is okay to not be okay. Next slide. Moving on to the available data on children and adolescents. This is data from a meta-analysis published in 2021. It shows the impact of the pandemic on children and youth globally. So 1 in 5 children and adolescents globally are currently experiencing clinically significant symptoms of anxiety, and 1 in 4 are experiencing clinically significant symptoms of depression. Next slide. As Ms. McAllister noted during the public comment, a state of emergency in children's mental health was officially declared in October 2021 by the organizations listed here. The reasons cited in the proclamation, including the ongoing pandemic, physical isolation, uncertainty, fear, and grief that children are experiencing, as well as a 45% increase in the number of pediatric self-injury and suicide cases seen at children's hospitals during the time period of January-June 2021 compared to the same time period in 2019. Additionally, the proclamation highlighted the disproportionate toll on young people in communities of color and inequities related to structural racism. So this declaration reflected escalating concerns among professionals everywhere due to trends that have been seen, and these same trends are being seen in Nevada. Following President Biden's State of the Union address on March 1st, which I'll talk about in a minute, where he specifically referenced children's mental health, the American Academy of Pediatrics is now calling on the Biden administration to declare the children's mental health emergency a national public health emergency. So this declaration by these groups urged policymakers to take several actions, including increasing federal funding to improve access to services. Again, Ms. McAllister went over this, but access to telemedicine, school-based mental health, integration into pediatric primary care, strengthening efforts to reduce youth suicide risk, and addressing workforce challenges and shortages. Next slide. So just a couple of months later, the Surgeon General released an advisory on protecting youth mental health. Excuse me, Surgeon General's advisories are relatively rare, and they're reserved for significant public health challenges that need the nation's immediate awareness and action. The advisory provides recommendations that individuals, families, community organizations, technology companies, governments, and others can take to improve the mental health of children, adolescents, and young adults. Later today, we'll review the recommendations for state governments in detail, but overall, the advisory emphasizes a whole of society approach to addressing challenges that have been longstanding for children's behavioral health. And the solutions should be resilience-based, support families and communities, and mitigate the mental health impact of the pandemic. Next slide. So I just wanted to pull this piece out. Something we'll talk more about today is the idea of mental health as an essential part of overall health. We need to recognize that behavioral health care is health care. And you may have noticed that myself and others on the HHS team use the term behavioral health pretty frequently instead of mental health or in addition to mental health. And that's because behavioral health as a term includes both mental health disorders and substance use disorders. And it covers the continuum of services from health promotion and prevention through intervention or treatment and recovery support. And it also encompasses health behaviors, excuse me, and other factors that may be influenced by social determinants of health. So we really like it as a comprehensive term that emphasizes not only needs, but also our approach to support and services. Next slide. Excuse me. So additionally, out of the White House recently, President Biden's State of the Union speech on March 1st reinforced many of the recommendations of the advisory. The plan calls for community-based, resilience-focused solutions. And I don't want to take up too much time, but essentially the recommendations were very similar with regard to schools, primary care clinics, integrating into other community-based settings that are more of a creative approach like libraries or community centers. And so I hope the themes are emerging here so far that we need to invest in school-based behavioral health, natural supports, community-based care, and support for parents and caregivers. And then, of course, investment in the behavioral health workforce is critical, including mitigating the stress and burnout caused by the pandemic. Next slide. So moving on to a little bit of data in terms of a baseline of where we're at as we think about making changes that align with national priorities. I'm sure that you've probably heard that we rank 51st overall for mental health, as well as 51st for youth mental health, according to the organization Mental Health America. They publish an annual report with rankings and break down the rankings in several different ways. So this is, excuse me, this has been the case on their annual report for the past several years. The rankings are based on different factors, including the prevalence of behavioral health disorders and access to care. We also have a local organization called the Children's Advocacy Alliance that does annual rankings on children's metrics. They recently produced a special children's mental health report card, which also indicated that we have substantial room for growth in our system in order to meet the needs of children, youth, and families. Next slide. I'll be very brief here and just point out that in the conversation on workforce shortages, we need to keep in mind that all 17 counties in Nevada are designated as mental health provider shortage areas. Next slide. With regard to school-based behavioral health, despite the fact that we've made significant recent gains, there's been a ton of hard work by Department of Education and our local school districts, but we are still quite far off from the recommended targets for school support professionals, including social workers, psychologists, and counselors. Next slide. In terms of providers available overall throughout the public and private behavioral health systems, we again fall quite far short of the recommended targets when it comes to licensed behavioral health professionals in Nevada. Next. So to summarize at this point, we've discussed the exacerbation of mental health need due to the pandemic, a system that was inadequate to meet the needs prior to the pandemic, significant behavioral health workforce shortages that predate the pandemic, and we're also currently experiencing nationwide a record number of folks leaving the healthcare field, which includes behavioral health care. So one of the consequences of this is that we've had a greater than average number of youth going into behavioral health crisis and seeking care in the emergency department. So just as one example, the emergency department at University Medical Center has seen increases in utilization. Similar increases have been reported nationally by the CDC as occurring during the pandemic. So as I discussed earlier with regard to the National Children's Mental Health Emergency Declaration, which was endorsed by the Children's Hospital Association, among others, we're seeing widespread reports nationwide from individual providers, hospital administrators, hospital associations, that changes in patterns of behavioral health utilization in the emergency department setting is contributing to staff stress and burnout. Next slide. In addition to the emergency department, children and families experiencing behavioral health crisis have been contacting the state children's mobile crisis response team at an increased rate since the onset of the pandemic. Thankfully, DHHS was recently granted American Rescue Plan funding to temporarily expand mobile crisis in order to meet the need, although the team does continue to work at or close to capacity. And of course, we'll talk more about crisis services in detail later today. Next. Finally, I just want to touch briefly on a well-being survey that was done in schools in Nevada in winter of 2020, primarily so that I can highlight these data from the caregivers and school staff. So as I discussed earlier, children don't exist in a vacuum. At a time when we're seeing record increases in depression and anxiety among youth, we're also seeing decreased capacity and confidence among caregivers that they feel able to help their child when something is wrong. Additionally, educators and school staff are leaving their jobs in record numbers, and those who have stayed are worried, they're stressed, they're burned out. So any parents, caregivers, or educators who are in the room or watching online, I see you, I acknowledge your struggle. I am a parent too. What you are going through right now is completely normal. It's not easy to fill any of these roles on a good day. And 2 years into a global pandemic, this is an extra tall order. So that's why now more than ever, we need to find creative solutions to support children, youth, and families, as well as everyone else in their orbit who has been so creative and dedicated in supporting them throughout this incredibly difficult time. Next slide. I do want to end by highlighting some of the successes we've had so far in putting in layers of support for children and families. We've been working in an interdisciplinary fashion to find creative solutions during a time of significant upheaval. The Nevada Resilience Project is through the Division of Public and Behavioral Health. It offers resilience-based support and linkage to services throughout the community statewide through a number of different creative strategies. We have a large group of stakeholders and local and state government folks working to address the children's behavioral health emergency in Nevada. Through these partnerships, we're creating new service delivery opportunities to meet increased need, expanding the service array, offering different types of services, and trying to, despite workforce shortages, trying to increase the capacity of the system. And finally, I think this just provides us with an opportunity to leverage the local and national awareness that we can see coming out of the White House and media reports, and just an increased awareness and willingness of folks to address the challenges of the children's behavioral health system and acknowledge that changes are needed. Next slide. That concludes this presentation, and I would be happy to take any questions.
Thank you, Dr. Freeman. That was really, I want to say eye-opening. It's not. I live this every day. I've got 3 kids, 2 in public schools. We deal with my oldest daughter's anxiety daily. I want to take a moment of personal privilege to also share my own struggle with mental health. I've had debilitating anxiety and depression most of my life. It's made things very difficult, especially as a child without resources. I have turned into a functional adult, but I still deal with it regularly. I also, in the last year or so, have realized that I have lived with undiagnosed ADHD, which has made life really difficult for me. I've always thought I was really weird, you know, like I couldn't deal with things normally like normal people do. The more we can get children access to care, to destigmatizing the request for help, the more functional adults we'll have in this world. I warned y'all this one was going to be a hard one.
This is Dr. Freeman for the record. Chair Peters, I just want to thank you so much for sharing that with us. I know that it is incredibly scary to share something like that with just one person in a forum like this. And I want to thank you for your incredible bravery. This is how we break down the stigma and build the system that we need to do exactly what you're saying, is make it easier to get earlier. Thank you so much, Chair Peters.
Well, I want to extend a thank you to all of the folks who are working in this area and for the support that you are creating for this generation of kiddos. And I hope that parents who are watching watch out for access to those and take advantage of them as you can. Your children need them and need your help getting to them. And without parents who can help them or other adults who can help children, it's really difficult to have and find access to those kinds of care and support. All right, thank you. I'm going to dry my tears and open up to the committee for questions. Are there any questions from the committee?
Yes, ma'am. Hi, this is Senator Spearman. How are you?
Thank you, Senator Spearman. Go ahead. And Senator Hardy, I saw you raise your hand so I will have you go after Senator Spearman.
Thank you. And by way of process, what I'll usually do, I usually raise my hand in the using the raise hand button. And just in case you don't see, I may start doing like this, but thank you. Chair Peters, I want to say, first of all, thank you for sharing your story. I think that it's very important that those of us who are in public service and to whatever the degree is that people think we've been successful, I think that it's important for people to know that we struggle. I was not diagnosed with my ADHD, went undiagnosed, I guess I should say, up until I started my master's program. And always thought, not weird, but just knew I was different. And there's always an amusement park going off in my head, I tell people. And so just trying to focus sometimes is a challenge, but I've learned how to do some of those things. Doctor, I just want to thank you for the report that you gave. A couple of questions, and these are themes that I have addressed in other committee meetings, not just during the interim, but also during this session. I know that COVID had an adverse effect on children in general and on families in general. But the complications and exacerbation which have confronted members of BIPOC communities is inescapable. When we think, and it's not just people of color, I'm thinking about especially those in indigenous communities. It has been my lament since we started talking and tackling some of the vicissitudes of COVID in the special session of 20, that we have not, at least I have not seen programs that have been designed specifically and culturally sensitive to the needs of those communities. For example, whatever mental and emotional health services that are available in communities of color, it can't be something one over the world. Call the county and they'll direct you to someone. As someone who's been Black all of her life, we just started believing mental health services 10 minutes ago. So I'm not going to go to someone that I don't know and making it, something as anonymous and even in some ways innocuous as go someplace to talk to someone about something. That's not going to happen. So that would be the first one. The second one that I'll say is that we did pass some legislation, a couple pieces of legislation. Both bills were mine. One was in 2017, where we passed a bill requiring the Secretary, the State Superintendent of Education, to provide another column next to the star rating for schools that listed the social determinants. And what that was supposed to do, it was designed to alert us as legislators and other agencies such as DHHS to know that these are some places where we need targeted support. And so when you stop and you look at the effects of COVID, and you look at especially in BIPOC communities where there have been generational deaths in one family, that I believe is a social determinant. When you look at what the fallout from the opioid abuse, that's a social determinant, and that is across social economic spectrum. But it has been more prevalent, if you will, in some of our more rural communities, and that we don't talk about because in the frontier communities, people are usually thought of as rugged and we can do this, but that such is not the case. So number one, what, if anything, have we done or are we planning to do to make sure that services are targeted specifically? I get the general, but I'm speaking about some things that we have to do with greater specificity if we're going to come out of this hole for BIPOC communities. And then how are we using the information that we're receiving from the COVID numbers to push forward to the Department of Education to say, these are some of the things that need to be included in the star rating. And along those same lines is the suicide prevention bill. And the number escapes me now. I believe it was 266, but I can't be sure. But in 2019, the suicide prevention bill required that all schools, and it was to be developed at the local level, would develop some system of education so that everyone who was in contact with students, that's teachers, staff, administrators, cafeteria workers, everybody would be trained in understanding some of the basic red flags, if you will, for suicide ideation. Because now that we're back in school, everyone hollered about, let's get them back in school. But now we're back in school and you have students who are dealing with this stuff and they're dealing with it in a congregational aspect. And that cannot not be easy. And Madam Chair, if you'll just indulge me, those are the first three questions. But and I just want to say these last two and then I'll be quiet. The other one that we don't talk about a lot are LGBTQ youth. And it's not just the LGBTQ youth who identify themselves as such, but it's youth who are in same-gendered families or in families that the composition doesn't look like Leave It to Beaver. And so we've got to deal with that. Then we have our seasoned citizens who the isolation, if you will, has exacerbated their loneliness. And I don't think that it is a coincidence that in Nevada, we have, if not number one, we're number two on completion of suicide by seniors. And last but not least, is there anything that we have done to work with Department of Veterans Administration or with Department of Defense, with some of the military bases that are in our communities, to make sure that military families, these sorts of things are being addressed for military families as well? Because unlike when I was overseas, all the schools were on base. And so that community was there. But in the States, the schools are out in the community. And unless people are attuned to the fact that someone may have a parent or even both parents who have been deployed, or a parent who has been wounded, a parent who's been injured, a parent who has even been killed in combat or whatever. So social determinants, suicide prevention, LGBTQ youth, seasoned citizens, and military families, and put all of that together in some targeted programs that are culturally sensitive, not agnostic, but culturally sensitive to the needs in these communities. And I'll be quiet. I'm gonna turn my camera off because the internet is unstable when it's on, but I'm still here, okay? And I'm listening. Thank you, Madam Chair.
Thank you, Senator. I'm so glad you were able to join us today. You bring up some really valid points, and I appreciate all of the work that you've put in through your tenure on these issues as well. A lot of your questions were questions that I also have, not just for Dr. Freeman, but for some of our other presenters as we move through the agenda today. So I would ask Dr. Freeman if you have any particular comment related to the questions Senator Spearman has brought up. And I would also ask that our other presenters who are here today consider some of those in their presentations as they discuss the particulars of what they're here to talk about. So Dr. Freeman, please go ahead if you have responses.
Sure. This is Dr. Freeman for the record. Through you, Chair Peters, to Senator Spearman, thank you so much for raising these important issues. One of the, we'll talk more about system of care later today, and we'll define what that means as a philosophy and as an approach to children's behavioral health services. But one of the underlying values is culturally and linguistically appropriate services. And I think that it's easy to sort of put a check mark and say, oh yeah, like we train our staff on that and we have a policy. And so like we're doing, you know, cultural competence or whatever. And obviously that's not the solution. I felt like you were peeling an onion while you were talking. And at every layer, I was like, oh man, like we need to be doing more. Oh, we need to do more on that. And it's all very complex and it's intersectional, right? So some children and families are going to fit into all of the specialized populations that you just mentioned. So while this is an area that we're extraordinarily committed to, HHS has been committed to diversity, equity, and inclusion, and has had some special initiatives related to that recently. It's something where, you know, you've never arrived, you're never culturally competent, and I can say that in terms of providing specialized services for these populations, that is absolutely something that we need to work harder at, and we need to consider the impact of the pandemic and the intersectionality, like I said. So there's absolutely room for growth here, and hopefully you will be willing to work with us because some of your thoughts and ideas were just incredibly valuable.
Thank you, Dr.
Thank you.
Freeman.
I'm here and not going anywhere.
Thank you, Senator. Senator Hardy has a question, and Assemblywoman Gorlow also has a question. We do have quite a stacked agenda at this point, so I want to encourage that these questions be specific to the data that was presented by Dr. Freeman, and that other questions may be answered by some of our other presenters down the line. This is a dense issue, and there are, like Dr. Freeman said, a lot of layers. And this is one of the reasons why it was really important to me that this be a substantial topic for our committee in the interim. So please go ahead, Senator Hardy, if you would.
Thank you, Madam Chair. I appreciate your courage. I come from a medical model, and I think one of the challenges that we have is being judgmental on people who, quote unquote, may have a perceived weakness. And the reality is these are real entities that have treatments, and then it's up to us to make affordable and available the treatments that exist, and over and above everything else, the hope that parents and children can have that we can help. I think one of the challenges that we've had that I'm not sure you mentioned is much as the screen time issues that we used to complain about, and then what we did is we magnified them when we sent the kids home with their tablets. And so it wasn't unanticipated that we would have problems, and sure enough, we have. But again, I think there's hope, and I think the medical model working with the behavioral model almost goes hand in glove on this. And I suspect you're seeing the need for the medical model, as Leanne McAllister was probably alluding to when she talked about the pediatricians. Thank you, Madam Chair.
Thank you, Senator. Dr. Freeman, do you have any comments or response?
This is Dr. Freeman for the record. I will just briefly say that integrating behavioral health services into primary care is an extraordinarily effective strategy and works very, very well elsewhere. And it's absolutely something that we should be keeping towards the top of our to-do list as a strategy. Thank you for the comments, Senator Hardy.
Thank you, Dr. Freeman. I absolutely agree. I've had a number of friends, family members, and colleagues over the last 2 years who have successfully addressed some of their behavioral health issues through their primary provider. And I think that has really opened a door to folks thinking that there's something larger going on with them and not having to kind of dissect what that looks like, instead have it be more holistic and accessible. Assemblywoman Gorlow, please go ahead with your question.
Thank you very much, Chair Peters, and I will try and make my question brief. I'm looking at slide 19 and really unsurprised at how short we are on behavioral health providers. Twice as many school counselors were short, 3.7 times for school psychologists, and 35 times for social workers. What suggestions would you have on policy or things that we could do to grow our own and also encourage others from out of state to come in? I mean, how do we fill those openings?
Dr. Freeman, for the record, through you, Chair Peters, to Assemblywoman Gorlow, thank you for the question.
Dr. Freeman, please feel free to go to the member directly, and that goes for all presenters today.
Thank you, Chair. Dr. Freeman, for the record, could probably talk about this for like a couple of hours, so I'll just keep it brief, which is we need to start with the pipeline. So we want to, and some of these initiatives are already happening. We're doing some great work already here in Nevada. We want to work with institutes of higher education to more closely integrate the systems. We want to make sure that folks know that working in public service or working in the schools is a great option, to give them the baseline skills that they would need to make that transition, provide practicum opportunities so that the transitions can be really seamless. But we also need to better incentivize working in those settings. We need to invest more in recruitment, retention, and compensation for the folks doing this work. And it doesn't have to be strictly salary. I think that student loan forgiveness is a hugely under-leveraged strategy, and there's other things that we can be doing. But it will take a very comprehensive approach to grow our workforce. We have to really show folks the benefits of coming into these types of careers.
Thank you very much.
Thank you, Dr. Freeman, and committee for those questions. We are going to go ahead and move on to our next agenda item and dive into some more of this issue. The next agenda item is youth suicide trends and prevention efforts. This one is hard. Please take your time and think about yourself also as we go through this topic. I know that it's already bringing things up for me. I don't know many people who haven't lived through their teen years and lost a friend due to substance abuse. So you guys, I'm going to pull myself together, I promise. Please go ahead. We have two presenters under this agenda item. We'll first hear on youth suicide trends and prevention efforts from Misty Von Allen, and she is online. Hello. She's also with the Office of Suicide Prevention. And then we will hear from the Safe Voice program at the Nevada Department of Education from Christy McGill, the director of the Office for State and Respectful Learning Environment. Our first topic under this is the youth suicide trends and prevention efforts presented by Misty Von Allen. Please go ahead, Misty, when you're ready. And good to see you.
Good morning, Madam
Good to see you, Madam Chair. Thank you so much, and committee members, for the opportunity to present to you. Madam Chair, I'm so grateful for your vulnerability in sharing your lived experience. As an Office of Suicide Prevention, we try and build a team that is willing to walk this talk. And it's really important that people can normalize these experiences, because I don't know a person who hasn't been touched in some way or other by COVID, and then the stressors that are ongoing. And if they aren't feeling the stress and strain, they sure as heck know someone who is. I need to clarify if my PowerPoint is properly being displayed. It changed since my last time. Are you only seeing the slide? Or are you seeing my notes?
Ms. Von Allen, this is Broadcast and Production Services. If you could please put your screen in full screen mode and start your presentation.
Unfortunately, it says it is in full screen mode.
If you could
challenge.
start your PowerPoint from beginning.
I'm going to leave and try again. We practiced this and it worked beautifully. And then something changed. Exit full screen. Enter full screen.
It appears to be in full screen mode now. Thank you.
Okay. There we go. Thank you. Everyone good. I appreciate your patience with that. No amount of practice seems to work. So I am the Suicide Prevention Coordinator and the Division of Public and Behavioral Health, and I have been in this position since 2005. So I have had the opportunity to see the challenges Nevada has gone through when it comes to mental health and suicide, where we were at the top of the highest rates in the nation. That started to change in 2001. So I'm going to give you an example of the 2020 statistics. Dr. Freeman did a beautiful job of setting the foundation and the national trends happening. So our latest numbers, about 60,000 people in the United States took their life to suicide. It is the first time suicide deaths have been bumped out of the top 10 nationally. And for Nevada, we dropped into the 9th leading cause of death in Nevada. I think COVID pushed that back out, the number of deaths in COVID. Firearms continue to be the leading method of suicide, nationally 52.8%, in Nevada 61.7%. When we had a focused reducing access to lethal means program, we reduced our suicide firearms deaths down to 52%, almost the national average. And then culture changed, circumstances changed, COVID happened, and firearm purchases increased, mental health stressors increased, and so you can see the dramatic impact on firearm suicide deaths up to 61%. Every 11 minutes, someone takes their life in the United States. For Nevada, we're currently the state with the 13th highest rate in the nation. This is only the third time we have been out of the top 10. But what I think is remarkable, 13th is still tragically high, and every loss to suicide is tragic. But you heard Dr. Freeman with our workforce challenges and access, that we're 51st on report cards and F on report cards. Yet our suicide rates in Nevada have maintained steadiness or even decreased. In 2018, we were the only state in the nation that decreased. Now, I know we had a long way to go, but we're headed in the right direction. Second leading cause of death for ages 8 to 44. For the past several years, it was the leading cause of death for our young people, so that has moved up a bit. And as Senator Spearman mentioned, our elders definitely have one of the highest rates in the nation, and over the decades, we probably have the highest rate. But currently for 2020, we are the 4th highest rate. That has continuously been a challenging population to get support and resources to combat this suicide crisis. We lose more people to suicide than homicides and car crashes combined, and that has always been the case. So focusing on our youth 0 to 17, we wanted to show you data from 2010 to 2020, because in 2020, there was a moment in time where there were several deaths by suicide in a very short amount of time. And we received national attention. The spotlight was on a certain region. And
people called it an epidemic. I wanted you to notice our two highest years were 2011 and 2018. 2011, I think we can deduce was probably linked to contagion, media contagion, linking it to bullying, a direct line. When we learn how to safe message and safe media reporting, that starts to reduce. 2018, I am not certain, but 90% of that increase came in Clark County, and I wonder, I can only speculate on the impact of the October 1 mass silence, maybe having a major impact on the community as a whole, as it must have, but we can't link that directly. As you see, 2019 and 2020 are relatively similar with 16 losses and 17, and then preliminary data for 2021 looks to be about the same with around 18 deaths that we need to confirm that. And as you can notice, the national rate has been steadily increasing for our youth as well, where Nevada's kind of all over the place. And part of that is to look at the years 2013, 2014, it does have a link to social media and on screen time. Absolutely, that is a huge impact on our data. We had a wonderful report come out from the Office of Analytics in February of this year that went into great detail and was incredibly helpful in writing grants and our state plan. And as you can see, the demographics, male to female, it's the national demographics for genders. It's about 4-to-1 typically. So you can see our female rate is a little bit higher. It's still close 4-to-1. We have the Hispanic Latino population coming with about 30% of suicide deaths. So we are paying attention to those changes in race and ethnicity. It's really important. Black and African American is also seeing some increases that we want to pay attention to. But these are losses to suicide. And I think what we really want to focus on are the suicide behaviors, the ideations, where I think some of the cultural impact, the racial impact will be profound. With method, absolutely, as I mentioned, firearms are a huge piece of this. When we look at our youth, much more male youth use firearms, and females, we see hanging, strangulation, suffocation. In current data, breaking it down, it was almost 50-50 from our child fatality review data. So we know one of the most profound programs that can impact suicide rates in our youth are reducing access to lethal means. And we have focused on this during COVID with COVID relief funding. We continue to share this message across the state, but it's very difficult to get this message to the families, to the guardians, that gun safe, medication safe, locks are really, really crucial and can give time and space to that person with thoughts of suicide. I wanted to bring this up. As I mentioned, we shared suicide death data, but where we're really seeing the impact, and I know our hospitals and our emergency departments and pediatricians, I'm hearing this so much, the emergency department visits, the inpatient care are increasing, especially for our youth ages 10 to 17. We are really seeing dramatic increases there. LGBTQ, Senator Spearman brought this up. We just do not have sufficient data on this. Across the board, I think the most recent information I can find nationwide is 2016, and it's just not good enough. Culture and climate have changed. But we do know for LGBTQ populations and youth, the high rates of suicide attempts and ideation double those that are non-SOGI. For transgender youth and individuals, 41% had said they attempted suicide. That's more than double those that are of the non-SOGI community. And we have to find better ways to connect these youth to the resources and support. Research has shown if a young person comes out as LGBTQ and receives support, resources, love, and respect, that reduces their risk for suicide and other mental health challenges. If they come into a a community or population where it's unsafe with discrimination, rejection, bullying, dramatically increases suicide rates. So I know there were bills to focus on this education, and we just cannot take our eyes off of this. We need to develop the safe spaces, and the Department of Education has done a beautiful job with the Office of Safe and Respectful Learning Environments. Incredible work, but we need to keep increasing building this connection and building the safe places with respect for our SOGI youth. Part of our relationship, Dr. Freeman mentioned the bridging of divisions and departments working together is so important across agencies, be it public and private entities. One of our wonderful partnerships with the Department of Education is Project Aware. It's a 5-year grant. We're in year 2, and really the Office of Suicide Prevention is just gearing up. Our role is to increase mental health literacy, training for families, school staff, and youth. Part of that wonderful partnership is with extra relief funding. Department of Education afforded the Office of Suicide Prevention to hire our first youth suicide prevention coordinator, a remarkable opportunity to really focus in on our youth needs. And one of the products of that will be to develop a youth suicide prevention strategy. We do have youth strategies in our overall state plan, but we want to hone in on the immediate needs with real-time data, and partnering with the Department of Education and DCFS, Division of Child and Family Services, is really imperative to that success. So training family and youth voice, as you hear, those with lived experience guide us. We need those voices to help us develop the plans. We need equity and diversity to develop culturally relevant and appropriate plans and strategies and programs. We hired a safe messaging expert with part of the Project Aware funding, and this person comes with lived experience and incredible knowledge on how to share our messages in a safe and healthy way, how to listen to the youth voice and gather those messages from our young people. I know they are having many struggles with COVID and after COVID, but I'm telling you, this generation wants to talk about mental health and mental well-being and suicide. They want to help their peers. So I see great opportunity in bringing them into this work, and they're going to lead us in a healthier way with our behavioral health and suicide prevention. Washoe County School District, the Charter School Authority, and Carson City School District are the local education agencies that are with Project Aware partners. As I mentioned, the Office of Suicide Prevention is gathering information through surveys on what the staff is needing, what they already know, what they're seeing, so that we can develop specific, appropriate district training plans that will really meet the needs of the staff and the families, and even peer-to-peer programs for those youth. We follow the multi-tiered system of support, and this kind of is an example of what that would be and how our work fits into that. We have the basic foundation. The Office of Suicide Prevention has been developing these trainings and awareness for 16 years, and now we need to get closer and closer to more tier 2, where we have focus groups, focus trainings for our parents or staff, and then we get to the more suicide-focused treatments. Access to those mental health professionals that can really deal with that individual's challenges to get them back into the tier 2, tier 3 needs. And I know Christy McGill will answer any questions about this so much more eloquently than I. I wanted to highlight some of the resources that are going on. Really great opportunities have come out of COVID as we've learned and had more opening up of the need for mental health supports. And NAMI of Western Nevada has had a warm line going for many, many years. And now in the near future, they're going to have the opportunity to develop a teen line. And again, when you're reaching out to someone with that lived experience and it's a peer, it shows the hope and possibility for recovery, that suicide is not the only option. There's other choices. And this warm line gives that person support as they build their recovery and work their safety plans. Another project they have, it's not necessarily for youth, Caring Contacts will help in that transition from care in an emergency department or inpatient care into their community and family with support as they work through their recovery and safety plan. So I just wanted to shout out that teen line to becoming. And then our regional behavioral health policy boards have developed incredible resources. Parents' Guide to Youth Mental Health in Nevada, how scary it is when they need to take their young person to the emergency department or inpatient care. What happens? How do they bring them home safely? And then for the hospital, what are the resources that can help support that youth in that transition? Excellent guides that the website is down below to access these online, but I really encourage wide disbursement of this important information. It helps this challenging and scary process become doable, more safe, which benefits recovery for that young person and the support system that they need when they come home. Dr. Freeman covered this very well, so I'm not going to go into great depth, but I just wanted to connect you to the links on this. And then also a couple weeks ago, there was a blueprint for youth suicide prevention that was developed with the American Foundation for the American Foundation for Suicide Prevention and the American Academy of Pediatrics. And it's an online toolkit with incredible resources. I presented to renowned pediatricians recently, and it had come out that day. And I think those healthcare providers who are definitely seeing the increases in youth showing up with that high anxiety, depression, and thoughts of suicide, this can be a really beneficial tool. In line with the healthcare that came up from several of you, Nevada has had our Zero Suicide initiative going for several years now. They are in their second round. They just completed their second round, 2.0, of a learning community where several entities, 48 individuals, attended a weeks-long collaborative learning opportunity for healthcare improvement around suicide safer care. Dr. Freeman is absolutely right. This is one of the most effective ways to reduce our suicide risk, our suicide behaviors, is that holistic approach. So it's not all on the healthcare providers or those hospital systems. The community has to be that wraparound as well. How does that person get to care, and what happens once they leave care? That transition is crucial. Follow-up is crucial. So we are really building a crisis response system to make this a safer state for mental health crises and suicide. On that note, I think I will open it up to any questions.
Thank you, Mrs. Von Allen, right? That's the two last name, or just Allen?
It's okay.
It doesn't matter. Okay. I just want to point out for folks who are watching and or listening that the links that were presented by Ms. Von Allen are on our legislative website, this meeting page, under Agenda Item 6, the youth suicide trends and prevention efforts. They can be found linked within this PDF. So if you are interested in looking more at some of those resources, they are available there. If you need help finding that, please feel free to email our committee email address or myself, and we will help get you those resources. Are there any questions from the committee? I believe Dr. Titus has a question. Please go ahead.
Yeah, thank you, Madam Chair. Couple questions. I see on the one presentation where you talked about the NAMI Western Nevada Warm Line and carrying contacts, and you gave a number there. I'm wondering about the status and coordination with the 988 hotline, and just worried that we have so many numbers out there. Will that number be directly linked to a 988 number, and perhaps then it will be automatically switched over there, or it can be transferred there when somebody calls, so that they get, as we use the term in healthcare, warm handoff from that line? And then I have a follow-up, if I might, please.
Thank you. Thank you, Assemblywoman Titus. Misty Allen, for the record. A great question. The interoperability challenges with 988 are being worked out, and that's a very important question. I will need to get back to you on that answer. Typically, NAMI deals with mental health challenges, isolation, recovery with mental health, and if there's a crisis of suicide, they would transfer it to the National Suicide Prevention Lifeline. 988 will begin, I need to emphasize this, July of 2022. So continue with the long suicide prevention lifeline for now. But absolutely that continuum of care, NAMI Nevada, Western Nevada, and NAMI will be a part of it. And I need to follow up on exactly how that transition might happen once 988 starts. I think in the building of 988, and I needed to address this in more depth, and that crisis response system, which will include a hub of the crisis hotline 988, 24/7 mobile crisis support, stabilization units, which are so much more appropriate for mental health crisis and suicide, and de-escalating that crisis in a therapeutic, less traumatic way with trauma-informed care, suicide-safer care is really crucial. So that is being built. Nevada is probably ahead of most states in the nation. We have some funding to support that effort. And the DHHS team has been working on this for years. So we are definitely poised to be a leading charge in this with Crisis Support Systems of Nevada answering those hotline calls currently with Suicide Prevention Lifeline. So I will confirm NAMI warm line and how that will be linked as 988 comes online.
Thank you for that. Definitely looking forward to moving forward with that 988. Another question I have, and then I'll have an observation. The concern, you presented the suicide ratio between men and women, or boys and girls type of thing, the youth categories and different categories that you broke down. I didn't see anything in the packet regarding suicide attempts, because it's my understanding that women attempt suicide more than men, but men are more successful. Is that correct?
Thank you, Dr. Titus. Misty Allen. The ratio nationally is women attempt 3 times per 1 male. Typically, the lethality is due to the access of lethal means like firearms or hanging. So as far as attempt data, we do have regulations coming on that to get more real-time attempt data. We do have trouble accessing that. But as you could see in the slide with inpatient emergency department ideation and inpatient care, that is ideation and attempt information that is increasing. I do not have syndromic surveillance data on gender, because I have seen it in the past where men are showing up at the hospital more often. So I can again check on that information for current data, but I do not have that.
Excellent, thank you. And thank you, Madam Chair, for the questions.
Thank you, and thank you, Ms. Allen. I believe that Dr. Freeman may be talking a little bit more about that transition to 988 during her crisis services presentation. So we look forward to hearing more about that. Are there any other questions for Ms. Allen? Oh, yes, go ahead, Ms. Allen.
Thank you, Chair Peters. I had a note here to address Senator Spearman's question. She asked wonderful questions, and we do have some answers, but I didn't weave it into my PowerPoint. But as far as service members, veterans, and their families, we have some incredibly wonderful partnerships with the Department of Veteran Services. We have a Governor's Challenge team to reduce suicide in service members, veterans, and their families. And we have 4 Mayor's Challenge teams in Las Vegas, the Truckee Meadows area, Winnemucca, and Elko. And each community develops their own unique needs around how we reduce suicide for service members, veterans, and families. It's comprised of veteran serving organizations, veterans, spouses. My co-lead, she's actually the lead, Sarah Hogue from the Department of Veteran Services, is a military spouse, so we have great wisdom and experience with her. And we have been brought into national presentations when they have the service member veteran family policy academies for other states coming on board. Nevada has been brought in to present as the subject matter expert. So we're really proud of where we are going as a team. As Dr. Freeman mentioned, those cross-department partnerships are such a bridge to much more effective care. As far as Indigenous communities and the BIPOC populations, DHHS and a wonderful resource, Social Entrepreneurs, has held several town hall discussions in Clark County around suicide in African American Black communities down there, and recently with the Hispanic, Latino, Latinx communities. We have so much more work to do, and most of that work is about listening, hearing the needs from the specific community members, what they're seeing, and really learning what is working for them currently. We also have been working with the Native American communities, and what I noticed, even in crisis, is they have the resources. They have the answers, and we can come in as support in the crisis. We can come in with hopefully funding resources or opportunities. But I find our role to be boosting up those elders, those experts in the community, maybe bringing in national resources who are much more experienced with working with Native American communities. The community I'm working with is bringing in a GONA in a few weeks, which is a gathering of Native Americans. And it's a beautiful starting point to address grief and loss and prepare the community for healing and prevention. So definitely huge gaps that we are trying to do better and support the communities who are doing it correctly, who are doing successful work with suicide prevention and mental health. Thank you for the opportunity to clarify that.
Thank you, Ms. Allen. And I just want to point out that last session we did, I worked extensively on a bill with Dr. Woodard to address that issue of the suicide attempt data and obtaining that. And hopefully those regulations will get us more access to that data and allow us to see kind of that whole picture as we're looking at suicide attempts and where to address those issues. And the other piece is I wanted to just make a statement about between your comment, Ms. Allen, and Senator Spearman's comment regarding cultural competency related to the Indigenous community in Nevada. This last session, we passed a bill waiving fees for tuition for Native American students in the state of Nevada. And I'm hoping that that access will encourage more and more of those community members to engage in higher education related to the medical industry. And ensure that they have representation that they feel confident and comfortable reaching out to, but also is competent and available to be at the table that they have historically been left out of. So I look forward to seeing how that turns out for those folks. Senator Spearman in the chat says, thanks, Misty. Are there any other questions from the committee at this moment? If not, we will move on to Ms. McGill and her presentation. All right, we have Christy McGill here for NDE Safe Voice Program. Thank you, Ms. Allen. The Department of Education Safe Voice Program, which we heard extensively about, I believe, in the 2019 legislative session. So I'm looking forward to this update from Christy or Ms. McGill. Thank you so much for being here. Please go ahead when you're ready.
Thank you. Christy McGill. I'm the Director of the Office of Safe and Respectful Learning for the Nevada Department of Education. And I'm here today, the PowerPoint's up. I'm here today to talk about Safe Voice, which is simply one way that our students can express their concerns either about themselves or others around school safety issues. So here is what it says it is in the law, and I just want to briefly take this moment to tell you what it really is on the ground. So what it really is a project that needs a whole lot of partners. It really is coordination between Department of Public Safety, Department of Education, our districts, and our schools.
Excuse me, this is broadcast. We need to interrupt for 1 second. We're not seeing your PowerPoint. If you could please stand by while we resolve the issue.
Thank you.
this broadcast. It looks like we are good, and you may resume the meeting. Thank you so much.
Thank you so much, BPS. Please proceed.
Thank you. Christy McGill, Director of the Office of Safe and Respectful Learning. So as I said, what it looks like on the ground is a collective impact project between Department of Public Safety, the school districts, and each individual school. Also, it is a way our students, and I would be remiss if I didn't have gratitude towards our students during the pandemic, because when schools shut down, they made sure that their peers were safe, and our students continued to use the program and not only report on themselves, but on their friends who they noticed on Instagram or something of that sort that were having some real difficulties. So in that way, we really felt blessed to have this program up and going. It is anonymous and confidential, which is a really good thing. The students say that that's a really important component, and it also leads to some complications sometimes, because to honor that anonymity and confidentiality, sometimes when youth are reporting either on themselves or others and it's a life safety issue, to really look at what are the pros and cons to go ahead and break that. So the magic behind Safe Voice is really the schools responding. And they respond to all different kinds of things, but schools have a multidisciplinary team that respond to the Safe Voice tips. And the tips kind of range from anything from, my teacher was being mean to me today, to I'm really worried that my friend is carrying a gun to school. I saw something funny in their backpack. So again, this is monitored 24/7 by our Department of Public Safety. If it is a public safety event, we also, DPS, brings in local law enforcement or the school resource officers, depending upon the district, to make sure that there is a quick and safe response to each one of these tips, especially if they're elevated on school safety. When school is not in session, Safe Voice is still live, and so we work really hard with the districts to make sure that that system or that ecosystem of support is around 24/7. We are also currently working with some of our community, especially around the mobile crisis teams, to come into the system as well to help with this for two reasons. One is those off hours when schools aren't in session. We really don't want our teachers and school counselors and school psychs to be 24/7 response. It's not healthy for them. And so to really make sure that we have some community partners in the system that can take the reins when they are with their own families or on a much needed vacation and those kinds of things, or off hours. So we're working with Dr. Freeman as we speak to see if we can embed the mobile crisis team into Safe Voice as well, so that they are an integral partner with our districts and schools to be able to respond to some of these tips. Again, Safe Voice, it is one way that we promote our students to express themselves around school safety, but it is not the only way. And again, we really look at anonymity and confidentiality, and we always promote our students to have those relationships with their teachers and school counselors first. So if they're at school, we always promote them going to talk with their trusted adult. But they're in a place that they don't have that, or many of this generation feels really comfortable texting over picking up a phone and talking. And they'll tell us, like, I couldn't say the words out loud, but I could text it. And so that component of Safe Voice, it is the main way the students interact with the platform is through text and not through the phone. Really the only users that use Safe Voice of the telephone are the adults. So the youth really use that texting component, and they have reported to us that that is an important piece, because sometimes saying the words out loud to this generation is more difficult. Part of the new legislation that was added to the bowling laws, which was part of the reason Safe Voice was created, was one, to really ensure the school safety around, it came from Colorado, around school shooting, but then also bowling, to be an early intervention so that schools could intervene early and disrupt some of these patterns. And so part of that bowling law was amended just last year to also include discrimination based upon race. And here, I won't read it to you, but here are the definitions that we added into that law to make sure that Safe Voice and our bowling protocols included those elements. And last, I just wanted to leave you with some of the important trends that we've seen in Safe Voice over the years since its inception. So I want to refer you to the blue line. That was the first year it was in the inception. So you can see that most of our students did use it indeed for bowling. And so bowling, and then of course next was suicide threats. And then we had the pandemic. So as you see in 2020, that the most popular tip that the students used to report in Safe Voice was suicide threats. So that was either they were worried about themselves or they were worried about each other and their peers. Again, just a big shout out to our students who I think really attempted to take good care of each other during the pandemic. As you can see, as the students went back to school, the suicide threats became less popular. And part of that, again, this is an ecosystem approach, is that we hope that when the students return to school, that there was earlier intervention so it didn't get to this point. And that things like bullying or concerns could be addressed earlier. I do also want to point out that as you can see this year, and as you've probably heard, that this year has been difficult for our teachers, school counselors, school psychs, school social workers. And as you can see, the planned school attacks really climbed in use for this year alone. So as you heard, I'm sure a lot of in the social media, in the news, and this just created more chaos and stress in our schools as the schools tried to respond to each one of these as they came through. You could also see that threat to student, that orange bar, has also increased, and we're seeing, again, some of the conflict as our students moved out of isolation and back into schools. Many of the behaviors that we didn't see before pandemic started to get more popular. Fighting, arguing, those kinds of things. And then also you can see that the school employee complaint also rose this year as well. So kind of those three indicators just are showing that our schools have a very hot, we call like a hot climate right now. As we lose many teachers and as we have fewer and fewer adults in the building. So we're really hoping that by all of us working together, we can kind of start to cool that climate for next year. And that's it from my presentation. If there's any questions.
Thank you so much, Ms. McGill. Are there any questions from the committee on this topic?
Madam Chair?
Go ahead, Dr. Titus.
Thank you. So, Ms. McGill, thank you for your presentation. Always good to see you. You've certainly been engaged for a long time in these issues. I drove down to Las Vegas this week for several meetings and am staying at my stepdaughter's house. And we had a conversation the first evening we got here about the increase in these planned attacks on students at both of my granddaughter's schools, especially the junior high, and I'm quite alarmed by that it's real. It gets taken down from social media fast, but those are realities that my grandchildren and people's children and other folks' grandchildren are living with. And it's not just located here in Clark County, but it seems to be pretty dramatic in Clark County based on, I think, definitely the population there's more students here, so ratio-wise. And I'm just concerned about, you can identify them, but is there any kind of a plan? Is there any kind of intervention? Because what I'm hearing is that the teachers can't intervene. There's really no intervention. The teachers are frightened here themselves about intervening. And I'm just wondering if that's being addressed.
Thank you, Dr. Titus. I just want to point out that our next agenda item also talks about this particular issue, prevention treatment efforts, but more specifically related to substance use disorder. So I would ask that our next presenters please keep in mind this question as well. I had a similar question, if I can tie mine in, if you don't mind, related to just the numbers of people calling in or sending in their concerns, and the disparities between the 3 years that you've been in operation.
Thank you, Christy McGill for the record. Yes, each school and district have plans in place to address planned school attacks. But as you can see, the frequency puts a lot of strain on the schools themselves. And so I do have two representatives from our largest districts here with me for the next presentation that can kind of go into more detail of what some of that would look like at the school levels. But yes, they all have plans to address this. It's kind of like the onion question, right? There's a lot of things going on. So, there is the strategies around restorative practices. There is trying the efforts to reduce suspension and expulsion. There's worries. There's less teachers in the building. We were doing listening sessions for the entirety of this week from our school system. And one of the clear asks that kept coming out over and over again is we need more adults in the buildings. With all of this turnover, our schools are not sufficiently staffed, and so you're seeing some of the results of that. So that is the kind of the overwhelm. Yes, there's things in place. Yes, there's strategies. Our districts do really well in that. But again, if we don't have enough people in the buildings, these don't go off as well as we'd hope. For the number of Safe Voice tips, I can definitely send a chart to all of you to kind of show exactly how many Safe Voice tips happen across months, across dates. We can definitely differentiate that. They're in the thousands. So again, one of the drawbacks, we love the system that this gives voice to our students, and it also does create a significant workload for our school staff, which most of them are really happy to engage us. They would rather talk about, they really love the kids. They would rather address the issues than not, but it does get, again, without the number of school personnel in our buildings, it gets really difficult.
Comment, if I might, Madam Chair, follow up on that.
Yes, please go ahead.
Thank you. So I hear what you're saying. I think that's one of the realities is that there's not enough adults in the room, but there's not enough adults in the room. And so that is the reality for right now, and that sometimes takes a while to resolve. One of the things that, just an observation that I'm seeing, instead of engaging the kids that may intervene and break up a fight, all the kids that I have seen on this, and from what I'm hearing, everybody pulls out their cell phone and videos the event. Nobody gets involved. Everybody's just standing there, putting it on their cell phones. And perhaps one of your solutions might be to engage the community of the students around, that it's, you have to do more sometimes than just film it. So just a thought. So anyway, thank you for what you're doing. Thank you, Madam Chair.
Thank you. And I would like to just clarify, so schools have planned attack plans, right? So threat plans. But what are being done around the issues of like suicide threats or bullying, and who are your partners in those efforts?
Christy McGill for the record. Again, we have our districts coming up, so they'll be able to tell you the specifics of what it looks like. But each school and each district has responses to suicide threats, which look at really trying to either work with community providers or our school-based providers to stabilize the students so that they are safe and that they can return to their school studies as soon as possible. As you heard in the last presentation, that many of our community organizations have waits. So again, this has put additional stress on the schools to really try to stabilize these youth. But again, when I look at the response to the Safe Voice tips of what the schools are doing, there's an overwhelming sense of care for the students, and they really do try to engage the community partners to make sure that those students are safe. A mobile crisis is key to this, obviously, in those stabilization plans, and why we really support our partners in the mobile crisis, not only coming into Safe Voice, but really, and they do already so much work with our schools, but even strengthening that. What does that look like? What does it look like to be co-located? What does it look like to share resources and supports? And we really feel like that may be the next step, and really providing that ecosystem of support that our students need.
Thank you for that. I know when I was a student in Nevada, we had a peer mediation program that I'm not sure how effective they found it to be, or if it's still in effect at this point. But I'd be curious to see if our schools still have those in place, if that's unique to each individual school. I believe ours was set up by the student council as an effort to reduce student violence against each other at the time. Anyways, I will ask those of the counties when they come up in a little bit. Are there any other questions for Ms. McGill from the committee? I'm not seeing any, and I apologize if I miss you. Okay, we're going to go ahead and move on to our next agenda item, which is agenda item 7, trends, prevention, and treatment efforts related to substance use disorder in youth. We'll have 3 presentations under this agenda item. The first will examine trends, the second will review prevention efforts, and the final presentation will highlight challenges and opportunities related to substance use disorder treatment in youth. Our first presentation on mental health, substance use, and adverse childhood experiences is by the Nevada Youth Risk Behavioral Survey, presented by Dr. Kristen Clements-Knoll, a professor and director of graduate studies at School of Public Health, University of Nevada. I believe she just popped on, so I will go ahead and pass this on to Dr. Clements-Knoll. Please proceed when you're ready.
Thank you, Chair Peters. Dr. Clements-Knoll for the record. I am the co-principal investigator of the Youth Risk Behavior Survey. Whoops, sorry, I didn't share my screen. I apologize, I thought I had it shared.
I just want to comment on your background on Dr. Clements-Knoll. That is so great, as the wolf pack background.
Yep, we're running with the wolves. Well, thank you for inviting me. I am going to present on behavioral health issues as a whole. I think Dr. Freeman did a nice job of introducing this. You really can't understand the trends in substance use without understanding the trends in mental health and all other aspects of youth lives. So I'm going to jointly present some of this information, but I think I have plenty of time to do so. I do want to thank our partners. We have a great deal of support from the Nevada Department of Education, the Nevada Division of Public and Behavioral Health, the Nevada Statewide Coalition Partnership, school district superintendents, their district staff, definitely all the school principals and administrators and the teachers, and certainly the students and their families. We conduct the Youth Risk Behavior Survey every other year on the odd years. Obviously, in 2021, no students were in school. So we did not conduct the survey in spring of 2021. Instead, we had to delay it to fall of 2021. We did exceptionally well, better than most other states, but unfortunately we do not have that data. We only finished collecting data by the very end of the semester. I'd be happy to make those results available or come back to speak with you, because I think the trends during the pandemic and return to school are going to be very important for us to look at. Just to make sure everybody understands the way the YRBS or Youth Risk Behavior Survey works in Nevada, we do receive funding from the Centers for Disease Control and Prevention, but that funding only allows us to sample 36 high schools for a state level YRBS. So those high schools are primarily in Clark County because that's where most of our population resides. We'll have a handful, maybe 4 or 5 schools in Washoe County and just a couple schools in our rural and frontier counties. So we're very fortunate that for many years, the Nevada Division of Public and Behavioral Health has been contracting with UNR to sample all regular public charter and alternative schools. We also do a sample of all tribal schools and oversample in that population. And what's unique in Nevada is we also include our middle schools. And today I would like you to pay very close attention to our middle school data because we need to be upstream and working with youth at a younger age. So we're very fortunate to have the funding to be able to include middle school students in our survey. We do work with districts, and in 2019, we administered the survey with either active or passive parental permission. It was about half and half in 2019. But as you all know, with Nevada Senate Bill 69, this has changed to passive permission statewide. I think this certainly helped us administer the survey at a time that was very, very stressful for schools. And it will only get easier in the future. We use a cluster random sampling design. I won't go into details, but just know that we weight the data to make sure that it accounts for any non-response bias, and so that our estimates are reflective of the communities in which we sample, and that we can compare over time. We do weight our data in our state at a district and regional level, and these regions align with our coalition partnerships. And it also ensures that we can present regional data without identifying the school. We never want to identify a school, and in some of these counties, we might only have one school that's available. In 2019, we had over 5,000 students in our middle school sample and just about 5,000 in our high school sample. That's typical. I think we'll have a little higher sample size in 2021. So first, I'm going to show you some data on substance use. This first graph is actually from the CDC sample, so it goes all the way back to the 1990s. And you'll see that use of alcohol, marijuana, and cigarettes peaked in the 1990s when I was in high school. Actually, no, I was in high school in the 80s when I was in college. But I want to really focus on the last 10 years. So from 2009 to 2019, you see that this decrease that we were seeing in alcohol continued throughout that 10-year period. That was a significant decline. A very significant and continued decline in cigarette smoking, and this is in the past 30 days. But use of marijuana has remained stable among high school students. This dotted area here in 2011, we did not have, I'm sorry, those dates are off there, but in 2011, we did not have weighted data. UNR took over data collection in 2013, and we've had weighted data since then. If we look at just our full comprehensive Nevada sample, and we compare what was happening from 2017 to 2019, you see that alcohol use and cannabis use is pretty stable, as we saw even in the 10-year graph with cannabis. Cigarette use continued to decline to a very low level, but we saw a rapid increase in e-vapor product use, and this was similar to what we saw across the nation. Non-medical use of prescription pain medicine in the high school sample increased slightly, but it was not a significant increase. There was a change in the way high school students were using cannabis, where there was a decline in smoking cannabis and a very significant increase in the use of e-vapor products. Turning to the middle school data, middle school youth are so young that it is important to look at lifetime use as well as past 30-day use. We see that use of alcohol was stable. We did see a significant increase in use of cannabis in lifetime in the middle school sample from 9.9% to 13.4%. There was a continued decline in cigarette smoking, but it was non-significant. And we saw the same increase that we saw in the high school sample with e-vapor product use. We did see an increase in lifetime non-medical prescription pain medicine use. And when I say non-medical, the instructions are using it without a prescription or in a way that was not advised by a doctor. And that increased from 6.8% to 10.3%. In terms of past 30-day use, we saw an increase in alcohol use. So this is alcohol use in the past 30 days. Again, we saw a significant increase in past 30-day cannabis use from 5.2% to 7.9%. Past 30-day use of cigarettes was extremely low in both years, an identical 2.5%. That same increase we saw in lifetime use and in the high school sample we saw with past 30-day e-vapor product use. We did not previously have a past 30-day non-medical prescription pain medicine variable. We do have that in all of our surveys going forward. In fact, we're one of the only states that actually assesses past 30-day use in middle school youth, and it's very informative. Similar to the high school sample, we saw that middle school youth were switching from smoking marijuana to vaping it in this time period. I'm going to move on to some of the mental health or emotional health outcomes. If we look at the long-term trends and focusing on, in particular, the past 10 years, we did see a very significant increase, and this would be the percent of youth who felt sad or hopeless. And I think it was almost every day for 2 or more weeks in a row where it inhibited their ability to do things. And we see that increased from 30% to 42.5% in 2019. So we will be watching this trend very closely in our 2021 data. In terms of suicide ideation, pretty similar in this time period. So last 10 years, 18.4%. This is in the past 12 months. A slight increase, but not a significant increase over time in making a suicide plan. And again, although it went down slightly, this is not significant in terms of suicide attempts in from 2009 to 2019. Looking closely at those, just that last 2-year period, we do see that same increase, and it was significant in that sort of depressive symptoms from 34.6% in 2017 to almost 41% in 2019. And again, you see that all of the suicide ideation, suicide plan, and attempt variables remain steady in that time period. We do ask a question on non-suicidal self-injury. That increased slightly in this time period, but it was not significant. Again, these are all indicators we'll be watching really closely when we get the 2021 data. Nevada has a state-added question trying to get from the youth's perspective whether they're getting the help they need. And so this would be when they feel sad, empty, hopeless, angry, or anxious. And again, I think it has that time period to the question. In 2017, over half, 55% of the youth said they are not. They rarely get the help they need. They never or rarely get the help they need. And that was very similar in 2019. So, I think we saw this in our earlier presentation by Dr. Freeman. This is part of the, the access to services for youth is one of the reasons Nevada ranks so low. And I think the youth are feeling this as well. So I want to point out something very important before I show the middle school data. In 2019, We made a decision after consulting with a number of stakeholders, including Misty Von Allen and others, who really want to evaluate the effects of their initiatives at the school district level. And to do that, a lifetime variable doesn't really help because you don't know when these things occurred. And so a past 12-month variable is much more sensitive. We also had really high rates of emotional distress in our middle school sample. So we felt like we really wanted to, in addition to lifetime estimates, get a sense of past 12 months. So when we look at comparisons, the gray bar is 2017, this is lifetime, but the blue bar is 2019. So they're not directly comparable because 2019, we're focusing on the past year. Even with that restricted time period, you see that there was an increase in feeling sad or hopeless. And again, this is, for most days of the week, for 2 or more weeks that interfered with their activities. 22% reported suicide ideation in the past 12 months, whereas previously it was about 21% in lifetime. 12.9% had made a suicide attempt. 8% had attempted suicide, and 19% reported non-suicidal self-harm. So all of these indicators, typically we will see much higher prevalence in lifetime indicators. The fact that we are seeing similar, if not higher, prevalence with our past 12-month indicators suggests that for middle school students, these indicators were trending in the wrong direction leading up to the pandemic. So we're going to be watching the middle school sample very closely. I know there was a question earlier, I think, can't remember, I think it was Assemblywoman Dr. Titus regarding suicide rates. And yes, in both our middle school and high school sample, it is higher. In our female population, it was particularly high in our middle school sample. 10.9% had attempted suicide in the last year compared to 5.4% of males. And similar to what we saw with the high school sample, about half of the youth do not feel like they're getting the help they need, and that didn't improve from 2017 to 2019. I added this slide, it's not in your deck. I can send you the full report, but this was a question that I believe Senator Spearman had asked. We do assess both sexual identity and gender identity in our high school survey only. This is just one slide speaking to one of the questions around suicide attempts. It is certainly high in the group of students who self-identify as lesbian, gay, bisexual, or they're not sure of their identity, 31% compared to only 11.6% of heterosexual students. And the same is true for our students who identify as a gender minority, transgender, or they're not sure. I was asked to talk a little bit about adverse childhood experiences. We do have a full adverse childhood experiences report for both our high school and our middle school samples for every year. So I will give you, I think you have the link to our reports in your slide deck. In 2019, we assessed, I think it's 7 different adverse childhood experiences: sexual abuse, physical abuse, verbal abuse, which is it's an indicator of ongoing verbal abuse in the household, witnessing domestic violence, household mental illness, and household substance use. And you'll see the prevalence is a bit higher in the high school sample. That's simply because they're older, so they've had more time to witness adverse childhood experiences. And we have created a ACE score in some of our reports and some of our publications. We actually look at 4 or more ACEs or 5 or more ACEs. Here we're looking at a high ACE exposure category as 3 or more ACEs. And you'll see that 20% of the high school sample and 15% of the middle school sample experience 3 or more ACEs. And if we look at the relationship between adverse childhood experience exposure and this is just one set of indicators, suicidal behaviors in the past 12 months, you see a very clear graded relationship as the number of ACEs increases. So in the blue, we have 0 ACEs. In the green, we have 1 ACE, purple, 2 ACEs, and that high ACE category, 3 or more ACEs. You see that the prevalence of suicide ideation increases substantially, and this is very significant, with 38.5% of youth who experience 3 or more ACEs, reporting suicide ideation in the past 12 months. 33.7% of youth with 3 or more ACEs had made a suicide plan in the past 12 months, and 20% had actually made an attempt in the past 12 months. So definitely a subpopulation where we want to focus our prevention efforts, and Dr. Freeman spoke to this as well, a need for trauma-informed services throughout our school system, but also working a lot closer with our families. We see a similar pattern. It's actually stronger, and we always see this in our data, where ACEs tend to have a stronger impact on the younger youth. So in the middle school sample, if you look at the suicide ideation in the past 12 months, over half of the youth with 3 or more ACEs had thought about committing suicide in the last 12 months. 34.7% in the high ACE category had made a plan, and over a quarter had attempted suicide in the past 12 months. Similar dose response relationship or graded relationship with all of our substance use indicators. This is just an example of some of our indicators for past 30 days. A significant increase as the number of ACEs increase, so does the prevalence of cigarette use, vaping, alcohol use, marijuana use. I could show you prescription, pain medication, injection drug use. All of the indicators follow the same pattern. And I think that was the middle school sample, high school sample, and then here's the middle school sample. Again, you see that very, very strong impact with the middle school sample and all of these indicators. So that's all I have right now, and I'm happy to answer any questions.
Thank you so much. Are there any questions from the committee on this data? I do not see anybody. Oh, Dr. Ohrenlicker, please go ahead.
Yeah, thank you for this very helpful presentation. And a couple of things I was curious about on the substance abuse numbers. Do you have data on frequency of use? I gather those are, did you use drugs at some point in the substance in the past 30 days? Do you also have data on whether we're seeing changes in high frequency of use? So that's one.
Yeah, we do. We look at the frequency of use within that time period. So this is just dichotomized. So often we'll look at use 20 or more days, which is nearly every day. And we're definitely going to be looking at that in the 2021 data. There's some indication that initiation of use may have decreased during the pandemic, but among users, frequency of use may have increased. I also want to look very closely, and this speaks to another question earlier, whether there are health disparities in what we're seeing. So for some youth, the stay-at-home orders may have been protective because youth were with their families had the ability to stay home with them. There was less access to substance use in some situations. In other situations, the families do not have that ability. A lot of our frontline workers and people who had to go to work multiple jobs, and youth didn't have the support of the schools and were left at home and in their communities. And I've done some other work in this area. So we'll be looking at really closely to see whether there's health disparities in the substance use patterns. But yes, we do look at frequency of use.
Okay. And if I could ask another question.
Please go ahead.
So you showed us for the different substances upward or downward trends. if we look overall, do we see an overall downward, upward, stable trend? And if it's, do we see, say it's stable, is there a rotation? Some substances are in favor, others out of favor, but sort of the population that's interested in substance use is maybe stable, but they may change into which substance they use. Do we have a sense of that?
Yeah, we have a sense that there is some substitution for alcohol use, for cannabis use, marijuana use, in both the younger population and the high school population. We do see our trends are similar to the nation. It's only a 1 year period, right, from 2017 to 19. But our middle school trends in cannabis use are similar to what we're seeing nationally, where the 8th graders and 12th graders prior to the pandemic had an increase in frequent use of marijuana, and we didn't see that in the older groups. So there's some indicators that we need to be watching that very early population, because their initiation patterns may be different from what we're seeing in the high school youth who may be substituting different things. The downward trend in overall in alcohol use and smoking cigarettes is very similar to the rest of the nation.
Thank you.
Thank you for the question. Can I ask about illicit substances, which are not listed in your slides? And can you talk a little bit about what those look like, if you have trends, and if you don't, why?
Yeah, so we didn't, well, first of all, illicit substances is kind of these are young adolescents, so they're all illicit substances for them. But if we look at methamphetamine, we have indicators of methamphetamine, cocaine use, injection drug use generally. Our rates are very low and have been stable. So we have not seen increases in any of those indicators. Heroin use. As I noted, we did have our high school sample. I didn't show you the lifetime data, but we did see an increase in prescription pain medication use in high school students for lifetime use. And you saw that there was an increase in the middle school youth as well. But all other illicit substances are stable and very low in comparison. And they've been stable for a number of years.
Oh, interesting. Thank you for that. Are there other questions from the committee? I'm not seeing any come up. So we'll move on to our next presentation. Thank you so much, Dr. Clements-Knoll. Our next presentation is on the statewide Epidemiology Organizational Work Group and the Multidisciplinary Prevention Advisory Committee. We have a couple folks, Elise Monroy and Jamie Ross, I hope I said that right, to present on this particular issue. I would go ahead and let you begin when you're ready.
Awesome. Thank you, Chair Peters. Wonderful.
We are seeing your notes. I think if you go into full screen.
Jamie and I are working together collaboratively from the north and south, which is one of the wonders of Zoom today. So she is probably frantically adjusting her screen as we speak.
Please let us know if you need BPS's assistance on that.
Thank you.
There we go. Thank you so much.
Great. Thanks, Jamie. Great work. Hello, committee. My name is Elise Monroy, and I am the chair-elect of the statewide Epidemiological Organization Work Group, which we lovingly refer to as the SO, because that's a mouthful. Next slide.
The SO was established in 2016 per guidance from the Substance Abuse and Mental Health Services Administration to provide and promote, to promote data-driven decision-making in the state Substance Abuse and Prevention Treatment Agency, or SAPTA. The SO works to advise the Multidisciplinary Advisory Committee, or the MPAC, which Jamie will present on next, and the SAPTA Advisory Board and other programs and grants in within DPVH SAPTA. The SO meets at least quarterly. And while these groups meet specifically to advise SAPTA's groups and grants, the EPI profile that the SO advises on, the data is used far and wide. Actually, many of the presentations that you heard from today, both Misty, Alan's presentation, and Dr. Clements Knowles pulled data from the EPI profile. So it's a great service to, I think, the state and public health and behavioral health that the SO meets to advise on an EPI profile. Okay, next slide, Jamie. The SO works in conjunction with the state's Office of Analytics to produce an EPI or an epidemiological profile. These profiles summary the nature and magnitude and distribution of substance or mental health related concerns. So for the 2020 EPI profile, the SO chose to focus on youth suicide because committee members and the state was just hearing anecdotal stories about the rise in suicides in our youth. So this profile told us, as Misty and others alluded to today, that while we know that historically suicide is the leading cause of death for adults in the state of Nevada, there is now a need to track and monitor risks of suicide for youth or young adults. And the last thing I'll point to with the SO is, next slide, Jamie, sorry, is the diverse makeup of groups that advise and provide insight to the development of the EPI profile. So included with this presentation is an attachment. I believe it's for this agenda item 7, I think it's attachment B, SO membership. You can see really the diverse range of perspectives, professionals, and experts that advise on the development and creation of the SO. And I think that this really diverse range of experts and expertise really provides for a well-rounded profile as we're picking which indicators and data to look at. But I think what now our work with the SO hands directly off to the MPAC, who you will hear from next with Jamie Ross to talk about how they are taking the data in the profile that we are putting together and then turning that and translating that into action. Jamie, go ahead.
Thank you very much. Can everyone hear me?
We can, thank you.
Yep. Wonderful. Good morning. My name is Jamie Ross. I am the co-chair of the Multidisciplinary Prevention Advisory Committee, which we also lovingly call MPAC because we have so many acronyms in our field. So just to touch, the SO finds the data, does the epidemiology, really translates the data into what does this mean, and then they give us a beautiful package and we review the data so that we can guide priorities for actual prevention work happening in the state. So we take this wonderful high-level data and really make it granular to determine the priorities. As with everything in our community, we would always want to be evidence-informed, data-driven, and so this is how we do that work. So what we did is we took all of the substances for both youth and adults. The Youth Risk Behavior Survey, which you heard Dr. Clements Knowles give a presentation on, is where the majority of this data does come from. And we focused on magnitude, time trends, comparisons, and severity. And really what that means is magnitude is, of course, how big the problem is. And then time trends is it going up? Is it going down, et cetera? I'm sure after watching what Dr. Clements-Knowles said, you have an idea of where this is going. Comparisons to other areas of the state and of course national, and then severity, so consequence data. And this process follows the SAMHSA Strategic Prevention Framework model, the goal of which is to prioritize 1 to 3 substances based on all of these data so that the resources that are of course very limited can go to the areas that are most at need. So this is the actual document, and these were the indicators that were prioritized. So the impact decided that anything that had a 5 or a 4 in overall score, unsurprisingly, these are marijuana and cannabis, or marijuana or cannabis, vaping products, alcohol, prescription drugs, and cigarettes. So we will move on to the next slide, and that really goes into more of the details. So these are the final priorities. For the group, one of the issues that I think Dr. Orenlicker hit on and Dr. Clements-Knowles spoke on in depth is that 30-day use versus lifetime use. Something that we have seen is lifetime use is overall a less good indicator than 30-day use, although more important for our middle schoolers. So that got taken out. And middle school students, the 2 areas of most concern are marijuana or cannabis and vaping and e-cigarettes. High school, it was use of alcohol and use of e-cigarettes or vaping. Adults, it was marijuana or cannabis, and then our LGBT plus population, current use of marijuana or cannabis and tobacco. The other thing I want to mention is we know the limitations of this data. A lot of this data is from 2019, and we are currently in 2022. And we have seen significant changes in the trends. And the data, unfortunately, as always, is lagging behind a little bit. So definitely continuing to carefully monitor fentanyl, pressed pills, kratom, et cetera. So then from all of those great priorities, we move on to what is actually happening in each individual communities. So each coalition in the state listed here, there is a coalition that covers every county in the state. We focus on those issues directly in our communities. I work at the PACT Coalition. We focus on Clark County. And to be able to take that data and utilize it in our communities is incredibly important. And to further tie all of this in, I think this is something that was also in the MPAC report. All of this is publicly available on the DPBH website. And something I find interesting is this funding source. So we've spoken on the 3 or 4 substances that seem to be emerging over and over in all of these presentations. And then the funding, the very pretty big green section of this is actually funding specific to opioids or opioid heavy. That teeny tiny little piece, that $50,000 at the very top, that is specific to alcohol. And I think one of the big priorities is that the drugs that are most affecting our youth are not really called out very much in this. Opioids are one of many issues in our community. Other ways we end up having to work is to leverage the funding that we have with opioids to work building systems basically on the back of these opioid dollars, and that really doesn't translate into sustainable systems. It creates some issues, and most all of this funding here is federal dollars. Very little of it is state general or state generated dollars. So most of this is prescriptive from the federal government. We understand that that is definitely an issue that continues to affect our community. You heard Dr. Clements-Knowles speak about Senate Bill 69, which created the passive consent of the Youth Risk Behavior Survey. It also institutionalized the prevention coalitions. And something else is it encouraged schools to create a list of evidence-based prevention programs. which really encourages that all areas of prevention programming in the state of Nevada are moving towards being evidence-based. And we wouldn't want to finish this presentation without giving you some gaps and some needs. If you look at the continuum of care, there is more money available for what we call primary prevention, which is either for parents who are raising children who are not currently using drugs, or young people who have never used drugs. And then we focus on what we call secondary prevention, which is folks who are at risk or currently using but do not have a diagnostic do not meet diagnostic criteria, and then early intervention for those folks. And then we move into harm reduction, treatment, and recovery. And of course, it is a lovely wheel. And there's very little funding for early intervention. Most of the funding that comes into our state is for primary prevention. And then the other issue we're having is funding not tied to a substance. To give you an idea, the last time the state legislature came together to fund specific issues around a substance was the first time we had our meth crisis. And obviously meth has not gone away, but and again, when we tie these drugs to a substance, then we have to be much more creative in how we're going to create these systems to solve these problems. Thank you so much. This is my contact information, and Elise and I are open for questions from the audience or from the members. Thank you.
Thank you so much, Ms. Ross and Ms. Monroy. Are there any questions from the committee on these topics? I am not.
Madam Chair.
Yes, Senator Spearman, please go ahead.
Yeah, I'm sorry. I don't know if Assemblyman Dr. Orlinger had his hand up first, but I'll acquiesce to him if that's the case.
Please proceed, Senator. Dr. Orlinger will be next.
Yeah, you were first, Senator.
Okay. So I guess the first question would be related to, so we've consistently had issues around funding to combat substance abuse for the larger population, but particularly when it comes to adolescents. Are there any plans to use part of the opioid settlement that's going, that will be administered? I think it's going directly to the AG's office, and then he has put in place a group of people who will further identify areas where it needs to be. That would be the first one. And the second one would be, and I put in the chat here, the bill that authorizes the State Board of Education to look at ACE. But is there any way for us to use what you just presented in terms of the substance abuse issues, those substances that are most likely not identified, but are most likely to be available and to be used by students? And is that clear or clear as mud?
Hi, Senator Spearman. This is Elise Monroy for the record. I will go ahead and try my hand at that one. So you had mentioned the settlement funds. So through Senate Bill 390, the state has developed the Fund for a Resilient Nevada, which is how dollars are going to be funneled into communities and to counties. I actually was kind of doing double duty today because the advisory committee, which I sit on, I was the Attorney General's appointee on that committee, met this morning, and we got an overview of the One Nevada agreement, which explains kind of how funds are going to come to the state through the Attorney General's office, go to counties and municipalities, and then to the Department of Health and Human Services. And the advisory committee that I sit on is currently working through a needs assessment process to identify what some of our community's needs are, with a focus on kind of historically marginalized and health equity, to ensure that as we're building out using these dollars, right, that are coming in from a settlement to meet gaps that have been long time gaps in our community around these services. And then I'm not familiar with the bill, but I will, we can look at that. I don't know if there's someone else who can speak to that, but yes, the settlement fund is looking to plug the holes kind of that Jamie mentioned.
Follow up, Madam Chair, and the other ones, Are we doing anything, are you working with the Nevada Office of Minority Health and Equity on some of these issues? Because it seems like there's some type of intersection between the information that you discussed and what the mission is for this interim.
So as it relates to the work on the SO, we don't engage directly with the Office of Minority Health and Equity, but that's something that is really easy for us to change. So we can start engaging with Tina and her team. And Jamie, I'm not sure if you work with them with the impact. Sorry, Elise Monroy for the record.
Thank you for the reminder, Jamie Ross for the record. And yes, we with the MPAC do not work with the Office of Minority Health and Equity, but I do believe, Elise, it was at the ACRN meeting that they along with the Minority Health Equity Coalition both presented on some of the work that they're doing, and they were intimately involved with the ACE. You sit on that, I just remember listening in. Is that your recollection as well?
Yes, and if the committee is interested, I'm sure someone from the ACRN would be happy to come and provide an overview of the needs assessment or our process as it relates to kind of filling and plugging in some of these funding gaps.
Thank you. And Madam Chair, last question, because it occurs to me that the dollars that we have, if there's more capacity building and collaboration, we can stretch. And then there's some areas that NOMI would be able to identify that may not be on your radar and versa vice. So just a suggestion there.
Thank you very much, Jamie Ross for the record.
Thank you so much for the question, Senator, and the responses, Ms. Monroy and Ms. Ross. Dr. Ornlicker, please go ahead with your question.
Yeah, I'd like to pick up on some of the things that in the past two presentations and also Senator Spearman's question, and that is going back to Dr. Clements-Knowles' connection of the adverse child experiences to substance use, and which makes me think that there's some maybe kind of self-medication going on. And when we talk about, and Dr. Rossi's talked about, we often make our funding substance specific, and when different substances are being used. But also, so that makes me wonder if we're doing more treating of symptoms rather than causes, that if to get at substance abuse, we need to really get more at the adverse childhood experiences, and that is that something we are able to do with the money that's targeted at opioid use to bring it down to earlier causes?
Jamie Ross for the record, I can definitely speak to that. I agree with you wholeheartedly that adverse childhood experiences and addressing the trauma our youth and adults are experiencing is incredibly important in reducing our risk factors, not just for substance misuse, but for all other negative outcomes. And so I will say that my partners who are in the both nonprofit and public as well as governmental sectors are incredibly creative in taking opioid dollars, because as of now, you saw most of the dollars that are coming in federally are opioid heavy, and really being able to be creative with how we address some of those issues. But in my field, we call that upstream prevention. Let's build fences as opposed to pulling people out of the river once they've fallen in. And I think that that is incredibly important and definitely something that those of us who are in the field of prevention are incredibly passionate about. And I am hopeful that the decisions made at all levels of funding include as much focus on really giving students, giving parents more tools in their toolbox, giving them the ability to be safe and healthy in their communities, because we know that that is an incredibly important factor. Also, just a small plug, the numbers have actually just gone up in the federal that I have read, and that is for every dollar spent on prevention, we save $18 in treatment and incarceration. So just a little plug.
Thank you.
Thank you for that question. I was wondering of something very similar, and I'm glad that we're broaching the subject. And those numbers are incredible when we're talking about the amount of funding that goes into these kinds of programs, and then what we can expect to see on the other side of that. It's hard in a biannual budget cycle to be able to look towards those kinds of benefits, but it's important to keep in mind as we talk about really the risk and the cost and benefits to our communities. So thank you for that piece of information. Are there any other questions from the committee on this particular topic? I am not seeing any. So I will thank you guys for being here and presenting on this issue, and we'll move on to the next portion of our presentation on substance use disorder treatment in youth, challenges and opportunities. We have Mark Disselcone, a senior project manager, Center for the Application of Substance Use Technology at University of Nevada. Please go ahead, Mr. Disselcone, and correct my my saying of your last name if it was incorrect.
You did very well. You did very well. I would say almost perfect, so I'm not even going to correct it. So I'm going to bring my slides up. Good morning, everybody. Still morning. I'm going to flip my slides. I know you see my presentation. That's weird. Okay. Here we go. And I'm going to flip my slides. Okay, Mark Disselcone, for the record. I do want to thank you, Assemblywoman Peterson, for sharing your story at the beginning. Very, very important. My brother is in recovery over 20 years. He almost died about 22 years ago, and he's been clean that long. And I just want to say that treatment does work, and it's important for people to share our stories. Okay, so I'm going to talk today about substance use disorders, treatment in youth, challenges and opportunities. And I'm with CASAT, and I'll tell you a little more about that in a second. So again, my name is Mark Disselcone, and I work for the Center for the Application of Substance Abuse Technologies at the University of Nevada, Reno, and I have worked with CASAT since 2003. I'm an LCSW and an LCADC. I was a treatment provider in Las Vegas prior to working for the Substance Abuse Prevention and Treatment Agency, which I was working from 1998 to 2003. It was the Bureau of Alcohol and Drug Abuse when I worked a long time ago. And then I moved over to CASAT and have been here ever since. CASAT started doing SAPTA certification for prevention coalitions, primary prevention and treatment programs in 2006. And actually, when I first came over to SAPTA in 1998, that's what I did. I did certification of programs. We have an excellent understanding of the treatment continuum in Nevada, as we've been certifying programs for a very long time. Since 1998, at least my experience has been. So the following information is just a snapshot of adolescent treatment in Nevada. SAPTA has adopted the American Society of Addiction Medicine, ASAM, as division criteria under Nevada Administrative Code 458 for the continuum of care in Nevada. It's a nationally recognized evidence-based approach to developing a strong continuum of care for substance use disorders treatment and also co-occurring disorder treatment. There are currently 30 level 1 and or level 2.1 certified adolescent treatment programs statewide. And I say and or is level 1 is any services that are under 6 hours a week for adolescents, and then any services 6 hours or more is intensive outpatient treatment. There are 6 drug court certified adolescent providers in the state. There's 1 medication-assisted treatment provider for adolescents. Methadone and Suboxone, age 16 is the FDA minimum age that somebody can be on those 2 medications. This is a OTP in Las Vegas, and they also do naltrexone as well. There are 3 level 3.1 and or 3.5 certified residential adolescent treatment providers. 1 in Elko and 2 in Las Vegas. As you can see, Nevada has limited access to adolescent residential treatment options statewide. More on this in a minute. So funding for adolescent treatment, and I'm going to pick up a little bit on those opioid dollars. I can add some, enhancements to that. So I do thank Jamie for excellent presentation related to preventions and the issues in Nevada and funding. Related to funding and reimbursement options for SAPTA certified providers, SUD, COD, so substance use disorders, co-occurring disorders, providers must be SAPTA certified and either co-occurring capable or enhanced to enroll in provider type 17215 with Medicaid. And that provider type is specific to both SUD and COD. It is not for mental health only, which would be like a provider type 14. Additionally, SAPTA utilizes the Substance Abuse Prevention and Treatment Block Grant to fund residential types of services, room and board, so forth and so on. Typically, outpatient services are covered by provider type 17215 under Medicaid. Jamie made a good point. There's a lot of dollars being spent from the federal level on opioids, but in the last round, actually SAMHSA included stimulants along with opioids. So some of those dollars now are being utilized for not just opioids, but they're also being utilized for stimulant treatment, prevention, so forth and so on. And there is word that because SAMHSA understands that there are other problems other than opioids in the country, that they're actually thinking of including alcohol as well. So that those SOR dollars, strategic opioid response dollars that come from the feds to the state, they are looking at expanding their reach as far as going beyond opioid treatment. There are other providers that are not required to be SAPTA certified in the state. In these cases, oversight is limited, and these providers typically take private insurance or private pay. Okay, so there are people outside of the SAPTA certified providers, but they are not receiving any Medicaid dollars or any block grant dollars from the state. I want to talk a little bit about certified community behavioral health centers and youth. CASAT is part of a team made up of the Bureau of Healthcare Quality Compliance, Medicaid, SAPTA, and CASAT, which oversees this project. There are 9 CCBHCs that fall under provider type 17188, which is specific to CCBHCs, and 6 additional CCBHCs that are funded directly from SAMHSA, SAMHSA being the Substance Abuse and Mental Health Services Administration, trying to make sure everybody knows what the acronyms mean. CCBHCs are required to serve children, adolescents, and adults, regardless of their ability to pay. There is no financial barrier to access to these services. It is noted that CCBHCs under this SAMHSA project only provide outpatient services, not residential services. Services that the CCBHCs provide are 24/7 mobile crisis teams, outpatient treatment, that would be like level 1 and 2.1, medication assisted treatment, both for substance use issues, but also for behavioral health, psychiatric rehabilitation and basic skills training, targeted case management, peer support services, and assertive community treatment services and teams. I did want to go back to what Senator Spearman asked about earlier. Under the SAMHSA requirements, each of the CCBHCs must specialize in VA treatment, and they are working having care coordination agreements with all local VA providers, and they are an extension of them and are able to provide services. Also, related to what Senator Hardy said earlier on primary care, 2 of our CCBHCs are also federally qualified health centers, FQHCs, and we have 2 additional ones that are applying for FQHCs as we speak. And just a note, because it was brought up earlier and it doesn't necessarily specific to CCBHCs, though they would need to provide this, is that I do work with Indigenous people in the state of Nevada, helping them with getting enrolled in provider type 47, which is something under for Native American populations, Indigenous people, so they can bill for Medicaid for substance use and mental health services. So I do that as part of my role at CASAT. Okay, so let's talk a little bit about some of the challenges related to treating youth and adolescents in the state of Nevada. With a basic understanding of the treatment continuum, here are some of these challenges. There is a workforce issue in Nevada, and right now it's very competitive, regardless if you're treating adults or adolescents. So that's one of the challenges. There are not enough clinicians that have the competencies to provide adolescent treatment. It is a very specialized level of service, especially when you get into the world of substance use treatment and co-occurring treatment. It even becomes more specialized. So we do have a limited workforce that's able to actually provide treatment at a level of competency that would be required. Adolescent treatment is specialized and takes more intense treatment over longer periods of time to be successful. Additionally, transportation and parents working like swing shifts create further barriers. I used to work for a provider in Las Vegas. We had an intensive outpatient program for adolescents. One of our biggest challenges was to get the youth to the program. The person that I worked for at the time bought vans, and the insurance for those vans was astronomical as you were transporting youth, so forth and so on. So that's another challenge that is unique to Nevada, with basically having 3 shifts that parents work during a 24-hour period. Another thing that you have to think about with working with adolescents is the developing brain. And they're, especially in early adolescence, females use for different reasons than males, vice versa. And treatment providers really need to know what they're doing related to screening, assessment, and making sure that those individuals get the individualized care that they need. Many providers do not want to engage related to providing adolescent treatment due to hiring competent staff and the cost of providing that care. It is a lot more work than just providing a traditional adult program. The success of an adolescent treatment program is only as good as its ability to engage resources to create a warm handoff. So really, adolescent programs trying to engage with community partners to assure that there's a relationship there and that people are getting referred for services is happening is very critical. Per what I said above, adolescent treatment generally costs more due to the intensity of services and the extended length of care to ensure outcomes are maintained upon discharge. There are limitations related to cost of services when comparing adolescent to adult treatment. That is not always reflected in the reimbursement of those types of services. So there are challenges, but there is also opportunities and strengths. So in many ways, there are really no limitations related to policy, as there is a continuum of care with a means to pay for services. Provider type 17215 is an example of a reimbursement mechanism for SUD and COD for adolescent treatment. The growing number of CCBHCs is critical, as these providers are required to provide treatment to adolescents, and it is very much supported by SAMHSA. This creates competition and encourages CCBHCs to provide more expansive treatment options, including adolescent care. What's nice about the CCBHCs is they do not have a choice related to providing services to children and adolescents. They are required to do it and have the staff to be able to do it, versus maybe just a standard SAPTA certified program where they're not necessarily required to provide those services. Helping providers establish strong referral relationships with schools, law enforcement, and other stakeholders is critical. So part of our SAPTA certification is we provide technical assistance to treatment providers, and we're always trying to encourage them to reach out to school counselors, work with juvenile justice, so forth and so on, to build a very clear referral connection between those entities and themselves. Lastly, actually two things to finish with. Education opportunities to build competency for counselors will encourage expansion of services to youth. And lastly, education opportunities related to adopting and implementing evidence-based practice is critical. A provider simply can't revise their adult program to treat adolescents. They must develop a person-centered care based on age and developmental stage. And again, going back to working with adolescents with substance use or co-occurring disorder, diagnosis is a developing brain and the ability to take that into account when they're screening, assessing, and then treating. And then the other critical piece here is family therapy, again, which is a specialized level of service. And if you're not doing family therapy as part of treatment to adolescents, your outcomes decrease significantly. Okay, questions, and thank you for having me today.
Thank you so much for the presentation. I'm going to ask the committee if there are any questions they would like to ask at this time. I am not seeing questions from the committee. I had a question related to that last bit that you talked about of of family therapy and the impact that has on success rates of treatment. Can you talk a little bit about the challenges of creating that kind of program and system for families?
Very good question. What's really critical, and I really share this with anybody providing adult or adolescent treatment, but especially adolescent treatment, is that you need to attempt to engage the family throughout the continuum of care, right? So too often what happens is that when you start off, the family is very resistant to getting involved, right? And so the goal is that use motivational interviewing kinds of approaches, try to engage the family at different points throughout the continuum of treatment to get them involved. So I think that's one of the key factors. And then really, I think that treatment providers need to start with the starting point of families have to be involved. So if they build a program and they have staff that are competent at that, you will see an increase of family engagement. Because I've seen programs that are committed to it and the families are involved. And then I see programs that are less indicated. It's much less part of their whole philosophy and they have a harder time. So I think the key is that it needs to be very much integrated into your treatment and that you need to do it across the continuum and get anybody involved that's a part of the family unit. It may not be the mom and dad, it could be grandparents, it could be other significant others that you want to draw on as well. So don't just look at the smaller family unit, look at the larger family unit too, to bring those individuals in. And you know, some of the data from SAMHSA shows somewhere between a 25 to 30% increase in outcomes when you do family therapy related to SUD and COD.
Those are really important numbers, I think. I think about the opportunities families have and some of the limitations that exist for families in engaging in these treatment scenarios, and the availability of sick time, paid leave. Those kinds of things are real inhibitors, I believe, for family members being able to be as involved as we would like them to be, not just in this particular issue, but across the board for behavioral health for students and children and youth. Can you talk a little bit about peer resources that are helpful in these treatment opportunities?
Absolutely. So the CCBHCs are actually required to have peer support specialists on staff or through contract, which has really enhanced, I believe, treatment. Really, what we in the past, before peer support specialists, is that you would get somebody through treatment, they'd be doing really well, and then they would get discharged, and it was almost like they fell off a cliff. But the peer support specialist can come up alongside them before treatment ends and provide a warm handoff into the recovery community. And so what we're seeing is an increase in outcomes because in longevity of recovery, because these peers come alongside and really bring people into the communities. A licensed clinician, you know, can't do that warm handoff and take somebody to a support group because it would be unprofessional under the licensing board. But with a peer, you can definitely do that. And so we've seen just an incredible amount of improvement related to clients having better outcomes because peers have come alongside while treatment is still in its active phase and then is there once an individual has successfully completed treatment and are out in the community.
I have a quick follow-up on that one. Is there a peer support opportunity for families? You know, the family handoff into support services for them as well, because it doesn't end at treatment, even for the families.
No, it doesn't. No, it doesn't. And that's the other critical thing is CCBHCs are actually required to provide both peer support to the client, but also to the families, right, as well, and be able to get them in connection, get them connected to resources, again, while the individual is in treatment, not at the end, right? So whether it be Al-Anon or other types of support groups for those individuals to get involved in, we're really working on that as well. The CCBHCs, you know, it was a heavy lift for CCBHCs, and they've come a long way, and there's a long ways to go. But you know, because we have such oversight of them, leadership of Dr. Woodard, for example, they're moving in the right direction, and we see a lot of these things really becoming more and more implemented and integrated into the community, and those services becoming more wide ranging, including the family dynamic and the services that they get.
Thank you so much. I don't see any other questions coming from the committee, unless I'm missing you. Oh, hi.
One question.
Senator Spearman, please go ahead.
Yeah, thank you. And I just had a real quick question. That is, you know, the recurring theme in all of these reports appears to be there's the connectedness between the individual that is, quote, in treatment, and then the family. So the question would be this. Are there any requirements for family systems therapy training, or maybe CEUs, or perhaps merging that with, and I'm thinking about Assemblyman Ehrlich's comment about we're treating the symptoms and not the root cause. So in all of the training that people that are working in this space, do they ever look at anything like family systems training? Because there's a presenting problem, and then there's a larger issue with the environment in which the person that we're treating is coming out of. And if you don't address that, then we simply, you know, kind of put a Band-Aid on it, send the person back into that environment, and the same thing happens over and over again.
Absolutely. And, you know, being a social worker, family systems therapy, systems theory is, you know, the bedrock of kind of what we do. Now, with that said, so all the licensing boards, and we have several in the state of Nevada, require clinicians to practice within their scope of work. Typically, that's more of a generalist kind of thing. So when you get into other kinds of specialization, like treating families or doing substance use treatment, so forth and so on, you are required to have a certain portion of your continuing education every 2 years in those specialty areas, right? So one of my specialty areas is SUD, which means I think I have to have at least 15 CEUs every 2 years in that particular specialty area for me to say that I can actually do that and practice in that. Other ways that you gain expertise other than just the education part is that you get clinical supervision from somebody who is an expert. So whether you're an intern working towards your license or you're already licensed and you want to, you know, build competency in a particular specialty area, it's really important for that clinician to find a licensed person that can provide that supervision for them. I know that I got some of my family therapy experience early on in my career because I did joint therapy with a marriage and family therapist as an LCSW. He kind of took me on. I did joint therapy with him, and that's how I built competency too. So traditional continuing education, finding ways to be supervised, finding a mentor to help you to develop those competencies, all are extremely important goals for somebody who wants to develop a specialty area.
Thank you. And Madam Chair, with your indulgence, just one more question. I know we've got a number of community partners that are available, particularly in the faith-based community, not for proselytizing, but you know, adjacent to what the professional licensing boards do. So if we're not, is there any opportunity for that? And while I've got the mic, just I'm not on, I don't have my camera on all the time because I'm having some internet issues. And if I keep it on, then I'm going to get kicked off and try to sign on again, kicked off. But I am here, for the record, I am here. And I also put into the chat a couple of bills that I spoke about earlier, Senate Bill 204 and Senate Bill 267. And I believe we had both of those in 2019 session. I think we had both of them in 2019 session. So that's just some context for everybody. So that's where I am. The faith-based partnerships are the ones that I'm thinking about that helps us to extend the opportunity to do what we do without having all the money to do what we need to do.
Absolutely. Faith-based organizations are a critical stakeholder. And again, we don't sometimes on the treatment side remember to provide to reach out to faith-based communities and have them help us. And, we can help each other. They refer people to the treatment system. The treatment system also refers back to the faith-based organization because of the support that they provide. And we know that any kind of structured support, 12-step or other, especially in the faith-based world, actually increases outcomes significantly. So I really glad that you brought that up. We CASAT actually did an initiative for an organization down in Los Angeles about 10 years ago related to faith-based, where we were helping them with some evidence-based practice stuff, and they were helping us on our end. And so that is an incredible thing to do. And I do tell treatment providers that, I mentioned juvenile justice and other kinds of entities in the community. I should have mentioned also faith-based communities as well.
Thank you so much for the question, Senator, and thank you, Mr. Disselkoen. Appreciate your presentation, information, and advocacy in this area. Are there any other questions from the committee? I am not seeing any, so we are going to go ahead and move on to our next agenda item. Thank you, Mr. Disselkoen. Appreciate you being here.
Thank you.
Agenda item 8. We're going to get through this and then break for lunch after this agenda item. No pressure. This agenda item is related to the implementation efforts of behavioral supports in schools through the multi-tiered system of support framework. We're going to, again, invite Director McGill to the table, and her, it looks like Catherine Loudon will also be presenting with her. Please go ahead, get set up, and proceed when you're ready. I missed a couple presenters. We'll also have Clark County School District presenting as well, I believe. Are they online? Okay. I think if we can get them pulled up if they're available. Thank you. Okay, see you there. All right, go ahead and get started when you're ready.
Good afternoon, Christy McGill, Office of Safe and Respectful Learning Environments. I'm here today just to talk quickly about the health supports in schools, especially one systematic approach that we call multi-tiered systems of support. I am joined by 2 of our professionals in our districts, both at Clark County and Washoe County, that will be able to kind of fill in a little more detail about what they are doing for supports around behavioral health services. So just really quickly, Nevada Department of Education there's 2 pots of money, and one, the largest pots go down to the districts themselves that around the recovery dollars, and the districts can decide where to place those dollars that best meet their needs. And then there's a smaller pot of money at the state level that looks at systems approach. And so NDE worked with its districts and key partners in DHHS to look at what could we do to provide additional funding to help our districts recover. So we looked at including additional dollars for school-based mental health professionals. We set aside $7.5 million. This is on top of what districts could set aside as well with their ESSER dollars. On top of that, we looked at how do we strengthen, because one of the things we learned through the pandemic was that schools that had intact multi-tiered systems of support fared a little bit better when getting supports out to children, and I can share those results with you soon. And so we looked at how do we deepen that. So we did put in some coaches that the districts could hire to allow those people to come in and really support the schools who wanted to deepen their multi-tiered systems of support. They could do that. We also looked at restorative training support. Again, the 2021 legislation looked at how do we move away from suspensions and expulsions and be able to teach behavior instead of punish behavior. And so we looked at trainings. This was a big gap. It's also a really big lift for our districts to do in the middle of a pandemic. And so we looked at how do we create a system of no wrong door for training so that if schools were ready for this kind of training, districts were ready for this kind of training. And so we either gave districts more money for training to train on their own, and we also created statewide trainings for our smaller districts so they could jump in and join. And then we also looked at Safe Voice program enhancements, especially around many of our after-hour calls are answered by our law enforcement officers. So how do we mix that with mobile crisis? How do we really make sure that there's a holistic response to these well checks on after hours? And so we're looking at rolling that project out soon as well. Multi-tiered systems of support is nothing new for this committee and for my partners at DHHS. It is the public health system. And basically, education has just kind of taken a look at that and said, how do we do that in school systems? So it is a system that looks at, one, teaming. We really want to make sure that teachers do not feel like they're independent and facing some of these struggles that their student may be having, so that there's teams involved. Also, problem solving around data to really make sure that our districts are empowered. We have Washoe County here, who is one of the leaders of really how do they empower their schools in database decision making. And then look at systematic implementation and progress monitoring. What we really strive for is that it's not enough just to put in the behavioral health supports for students, but we really want to make sure that we have a system that can progress monitor and to make sure those interventions are actually working. And then tiered continuum of supports. A lot of times this is what people think about when they think about MTSS or multi-tiered supports. And this is about differentiation. The goal is really trying to get supports and interventions to students early and to make sure that they have, as soon as they have signs of struggle, that they have those supports ready for them. And so we're not catching them in special education or 3 years down the line or when they enter Safe Voice as really struggling with their behavioral health. It also really stresses on Tier 1, and this is something that our schools do really well. Tier 1 is good, strong, preventative instruction and good instruction across the board to all of the students. And so that is where our teachers come in, our school counselors, and then regular screening, evidence-based interventions. So this is the system around MTSS, and of course it focuses on equity, because if you have a system that differentiates support and interventions when students and staff need them, then you create more of a system that is equitable. I put this here in for you guys just for your notations and reading enjoyment that kind of goes through the different tiers that you guys can refer back to. But again, just like the public health model, tier 1, 2, and 3, the universal supports for all students, targeted interventions for students at risk, and then individualized supports for a few students. And that's where some of the clinical work can come in, and our school-based health can help support that. Just some really quickly, I'm going to go through some of the outcomes. So we had 10 districts really look at this inclusively. That equals 149 schools and 99,000 students and 41 trainings. So this happened throughout the pandemic despite some of the difficulties. And again, I just put this in here for your quick reference to kind of look at the types of trainings that our UNR Technical Assistance Center. And again, I should really preface that our office is quite small. We wouldn't be able to do any of this work without our partners. And one of the key partners to MTSS is UNR. Department of Education has a technical assistance center that looks at positive PBIS, positive behavior interventions and supports, which is part of MTSS. So these are the trainings that a school and district would go through if they so selected to use the multi-tiered systems of support, which also helps them meet the requirements around Nevada's integrated systems that was also put into place, I believe, 2 legislative sessions ago. So just real quickly, I wanted to end on some positive notes that when schools do this with fidelity, we do see improved climate for teachers, and then also improved student outcomes. So here you can see that one of the goals is to try to tackle the issue of teachers feeling, and school counselors and everything out, that there's too much on their plate. And so really looking at how do we look at one system, multiple practices, not multiple systems with multiple practices, and it feels very overwhelming. We haven't got this down yet, obviously, but this is one of the things that we are working for. We have found in schools that are implementing with fidelity that it does seem to reduce that feeling of being overwhelmed. And some student outcomes, again, you'll notice some really large data swings on the outcomes because, of course, of the pandemic. But what you'll also notice is that many of our MTSS schools that are implementing with fidelity are also schools that are have exhibited either are at Title I or are struggling in some sorts, and so they're doing this. So as you can see, that the schools that have implemented MTSS had less harmful outcomes of the pandemic. So they had more students coming. Their absentee rates were better. And then if you look at some of, I included in here in a couple of slides, the violence to students, violence to staff, progression of weapons. Again, you saw that you can see that the schools that are implementing MTSS with fidelity have better outcomes than schools that are not. Also trends in controlled substances. And again, MTSS is nothing more than a system of using evidence-based targeted interventions to issues that the schools have to make sure that when staff and students start to struggle, we have the appropriate interventions and supports at the ready. And also, of course, good teaching and prevention. Again, also results in bullying. So I went through that very quickly because I wanted to allow some time for our districts to talk about the behavioral supports and what they're doing during this time as well. As noted, I believe it was Dr. Freeman, that despite some of the ratios, and Nevada has not met its ratios on school counselors, school social workers, and school psychologists, so this workload during the pandemic became a lot. And so we are striving to better those ratios and working with DHHS closely. One of those ways is to look at Medicaid, and instead of using educational funds for those Tier 3 services, which we're doing a lot of, is to bring in that Medicaid dollars to offset that. What we hope is that this results in a larger budget for schools to purchase more people to come into the schools, school psychs, school counselors, school social workers, and that to better those ratios. So I'm going to turn it over to our Clark County, which I believe is Miss Director Weirs. There he is. And also Joe Roberts, who runs the crisis intervention team there.
Welcome. Thank you so much for being here. Please go ahead.
Good afternoon. For the record, Bob Weirs, Director of Psychological Services, Clark County School District. I'll just share for a minute or two, and then I'll ask Joe to share and see if we can help answer some questions. As the Director of Psychological Services, I have direct oversight. I have oversight responsibilities for all of our licensed school psychologists providing psychoeducational services across our schools. And I'm also actively involved with our multi-tiered systems of support efforts within the district. So one of our specialized sub-departments is our crisis response team. Joe will speak to that and some of their responsibilities and roles. But also our department has actively supported development of schools that follow multi-tiered systems of supports and positive behavior interventions and supports with some collaboration through, as Director McGill said, the University of Nevada, Reno PBIS Technical Support Center. So we were up to approximately over 100 schools that were actively pursuing implementation of PBIS related practices. As a Director of Psych Services, I do a lot of communication collaboration with other departments, key people related to health and behavioral health. We have active engagement and collaboration with our counselors, our wraparound services that include social workers and safe school professionals, our health services, school nurses. Of course, we work with crisis response team as well. We also have interface with community agencies, community groups. I'm the district representative to the Clark County Children's Mental Health Consortium. We have collaborative activities with the Mobile Crisis Response Team, the Harbor, and so on. I'm also a standing member of our district's MTSS district leadership team. So we are moving forward step by step. Just this past December 2021, we passed a district policy more formally endorsing MTSS practices in the district. So that's a basic overview. I can come back after Joe introduced himself. There were some of the questions earlier this morning that we can provide some feedback on what's happening in Clark County School District, but we very much are aligned with mental health types of services within the Clark County School District. Joe?
Thank you, Bob. Joe Roberts, Director of the Clark County School District Crisis Response Team, for the record. To address some of the questions and to speak to Director McGill's points there regarding behavioral mental health supports for students in our schools. We have and we did initiate prior to the pandemic, we had revised our suicide risk assessments to align with the Columbia Lighthouse Screener. We have moving forward in through the pandemic, we recognized the need to, while we were closed, to still have access to our school-based intervention team staff, school psych, school nurses, school social workers, and school psychologists in the district. And we initiated a district-wide effort and collaboration with building principals and wraparound services, psych services, school police and whatnot throughout our district to engage in what we coined the term the Lifeline Project, which was to allow students to initially raise their hand during an online session and make an appointment to be seen at a school site for crisis support. And coming through that, we also embarked on a very lengthy and involved project with developing a screener, panorama screener. And we're still using those tools today. We also engaged in alert monitoring district devices for students who were expressing suicidal ideation or even perhaps considering an attempt, those types of things, through what's known as or coined as Beacon Go Guardian, in addition to, and that complemented our efforts with our already engaged efforts with Safe Voice. So we were able to, I feel, and our numbers show, we were able to turn the tide on our completed suicide rate. And then moving beyond that, we already had existing partnerships with, say, the Harbor, with, as Bob said, the Mental Health Consortium, and with Mobile Crisis Response Team. But however, coming through the pandemic and during the pandemic, we solidified even more so those relationships, and we appreciate our partnerships with those agencies. As far as other efforts are concerned, we increased our level of training for suicide prevention to all of our staff in the district. And also too, we expanded some other factors or some other key components like our suicide SOS curriculum and training for our students grades 7 through 12. And we can answer those questions more specifically in the next piece here. Thank you.
So again, Bob Weirs for the record, Director of Psychological Services. So some of the questions earlier, Joe just started to answer that. I believe the statute with Senate Bill 204, 2019 required increased awareness training relative to suicide prevention, warning signs, indicators, both community and school resources and basic information. We included basic informational procedures. So for the past 2 years, looking at compliance with Senate Bill 204, we have been offering suicide prevention training to administrative staff, licensed staff, and support staff. In terms of the earlier question about developing systems, we are working mightily to develop infrastructure for multi-tiered systems of supports. We're playing a little bit of catch up on the behavioral side. Of course, we're looking at the all-around development of students, academic behavior, social emotional, encompassing behavioral health. We are building infrastructure. Coming off the pandemic was a huge impetus for us. As Joe mentioned, through the Lifeline Project to develop multidisciplinary leadership teams, which are basically problem-solving teams for at-risk students. So to complement what we had available for academics for kids. So we are moving forward with developing infrastructure and practices. We are expanding upon mental health services and supports. Recently, the district engaged by example in working with Care Solace, which helps us facilitate connecting families with community providers. So there are a number of activities that are going on, and Clark County is in the process of developing step-by-step the infrastructure related to multi-tiered systems of supports. There was an earlier question about safety procedures, plans, and also specific to suicide ideation. Joe answered that in part, but I'll try to add to that information. As Director McGill mentioned, schools all have safety plans in place. We have a plan for the entire district for large crisis events, whether that's a school, a group of schools, or the entire district. Emergency Management Department helps us run that. It ties into all elements of the district under a master plan. Probably the best example of the last time that was fully engaged, apart from the pandemic, some activities was the October 1 tragedy, where we were mobilizing response resources relative to that tragedy. Each of the schools trained every year on safety. They go through soft lockdown, hard lockdown, evacuation procedures with assigned responsibilities at the level that applies to all facilities in Clark County School District. For example, I work at a centralized office, Dr. Beth House Center. I'm on the safety team. My responsibilities specifically are, in addition to helping with head counts, make sure everybody's accounted for. Part of my responsibilities are ensure, assess whether there are any mental health needs and to help provide and coordinate services if in fact they're needed. Heightened sensitivity. I believe the Assemblywoman mentioned that this morning. Just our last CCSD Board of School Trustees meeting specifically had an agenda item that was talking about safety issues. So there are plans in place. There's heightened sensitivity, and the district continues to look at safety issues for students and staff, safety for all students and staff. Jill and I obviously line up a little bit more deeply with the mental health side. So we have a comprehensive, what we generally refer to as a suicide intervention protocol, where Joe's talking about updating our risk assessments. Our procedures go from any kind of question or concern relative to a student, through intervention, through screening and assessment, through intervention at school level, up to the few cases where we actually need to help facilitate hospitalization of students for appropriate assessment. Those are standardized procedures. We've done a very good job, in my humble opinion, over the last 5, 6, 8 years of standardizing those procedures, making sure we're clear about them. All of our first responders at the school level, which is some combination for a given event on a given day of a counselor, social worker, safe school professional, nurse, psychologist, and including, of course, administrative support. All those people, when they're new to the district, are trained in our suicide intervention protocol, procedural steps, forms. And all of us are occasionally receive refresher courses so that we make sure that we're aware of what our responsibilities are. So from the suicide ideation side, I know that was a question earlier today. I feel, again, from my professional opinion, that that's well established, well standardized, and it's a good, it's a strength of the Clark County School District. Challenge of the district, obviously, is to move more proactively, get more to the at-risk kids, move more into the educational, what are we doing with all kids? How can we increase awareness? How can we increase that? So across the board, I did want to share that. We are making progressive steps that reflect Nevada legislation in relation to increased awareness. That includes training with students and staff. We do have a mechanism in place for response in relation to suicide ideation. We are continuing to look at the district level for planning and support for schools so that we can progressively ensure that we're meeting the academic, behavior, social, emotional, and including behavioral health needs of kids. So
thank you. And
thank
you. Thank you for making the distinction between the proactive efforts and the reactive efforts. It's necessary to have the reactive efforts in place, but the proactive pieces are what we're really seeing as being as making a difference to our students. So I hope that our focus can continue to be in that space. I would like to hear from Mrs. Loudon about what's going on in Washoe County. So if you wouldn't mind sharing briefly, if possible, and then we will break for lunch.
Thank you very much. For the record, my name is Catherine Loudon. I coordinate school counseling and social work for the Washoe County School District, our emerging school social work program. Washoe County School District has an MTSS department headed by Trish Schaefer, who also heads social emotional learning. Our district has a robust website with lots of great information about how this incredible MTSS system helps with data-based decision-making related to how to support schools and students in an individualized fashion. The collective impact of the pandemic on our students and families and staff was very significant. Many of you are aware that Washoe County School District did open. This was something that was very important for our families. We tried as a district to implement stress relief wherever possible for staff and others. We also worked collaboratively with our community members and agencies, as well as state agencies, including the Nevada Department of Education and the Division of Child and Family Services, including Megan Freeman. We have found that due to the lack of availability of supports and the pipeline to success for these critical mental health personnel, what we really need, in addition to continued sustained funding for these positions, is that co-located, integrated supports. We need our mental health professionals and our substance misuse professionals to come into our school and to work side by side with us. And that is something that we have been implementing and working collaboratively toward. This is essential to address the barriers to access as well as the critical needs that our students and families and staff have, and to enable our educators to build their own capacity to continue the work that's very important for them to do, and also be able to address things like the psychological first aid of students. Washoe County School District implemented a behavior hotline for parents. We collaborated with marriage and family therapists on some teacher support groups and staff support groups and efforts. We accessed the Nevada Department of Education's trainings that they had. We worked to continue to expand what we were doing in telehealth, and that is something that is also necessary. There are issues with that, including costs. We responded to death, grief, loss, and crisis, and have implemented our robust programming around suicide and substance misuse in conjunction with Senate Bill 204 and 69, as well as the reporting of suicide. I would like to say, because I think it's so important, that we in Washoe have continued to see increases in the outcomes as we have moved forward with what we have been doing with suicide prevention. We educate through the Signs of Suicide program all 7th grade students and offer screening. And that's something that we have seen substantial increases with the reduction of stigma for parents to participate actively in that program, and also seen results as far as our 19 middle schools are concerned, with as many as 35% of students screened with that active permission coming up with needing some additional support. We have been collaborating with our Northern Nevada Mental Health Consortium, and that have contributed to their recommendations and access the professionals in that group. We are a Project Aware, a SAMHSA Project Aware school district, and we appreciate that and the work that that has had with the Nevada Department of Education and the stakeholders there, in addition to building the capacity to better record keep and support what's been happening with mental and behavioral health. And I think a missed opportunity is for all of us, and especially considering the individuals that are on the call today, to share about the shared risk and protective factors that cross boundaries as we're addressing things like suicide and substance misuse. And as a district, we've suffered so much with student overdoses, in particular related to fentanyl, and that's a concern that we have. But when we are using and employing strategies to prevent suicide, we are preventing substance misuse, we are addressing gangs, we are addressing so many things in the field of prevention related to violence and otherwise, that I think we could learn a lot from that work and some of the prevention work that the Center for Application of Substance Abuse Technologies and others have put into place for us to benefit from. And I will stop talking about this stuff to allow for some questions, but I too, in Washoe County School District, participate in crisis management and emergency response, as well as the way that we address crisis, death, grief, and loss in our schools and serve on our district school safety team. We are all National Incident Management System compliant, and we have an emergency manager. We are working to improve our processes with our community agencies, including our local law enforcement and emergency management system. And that's all I have for you, and we'll answer more questions about this or other trauma-related things that you might have. I'll try.
Thank you for the presentation on how things are going in our largest school districts. The emergency response team work is really an interesting space. I get to do it with hazardous materials, but it's really interesting when you dive into the community emergencies. I have a quick question. I guess it's a follow-up question. You don't need to respond today, but I would like to, from both counties, get any kind of reporting that you have on your, as Ms. McGill pointed out in her presentation, system implementation and progress monitoring efforts. So if you have quantifiable or even qualitative indicators of how successful your efforts have been over the, I would say, last 5-year period, maybe, to give us a couple years before the pandemic, that would be great to see. And then with that, I will open it to committee questions. I see Senator Hardy or Dr. Hardy has a question.
You talked about fentanyl overdoses. Are you having experience of those overdoses happen at school and have Narcan, naloxone available, or do we have those in the buses, or are we equipping our people with ways to reverse overdoses?
For the record, this is Catherine Loudon with Washoe County School District, and then I'll turn it over to my colleagues in Clark. Yes, we have experienced the impacts of overdoses that occur outside of school, but we have had overdoses, including fentanyl, on our campuses, and it is a concern. We have taken advantage of the availability of Narcan and collaborated with the community agencies that are in place to put that together. Our district has a policy through our director of school nursing, and we are implementing that currently. And working on that in our district's policies at this time. HIDA had a presentation, the High Intensity Drug Agency had a presentation for us at the beginning of the year and connected us with some resources through our community coalition, Join Together Northern Nevada. And then we collaborated with the other stakeholders to implement that in our schools.
Thank you.
I see Mr. Roberts' hand up. Do you want to respond for Clark County?
Absolutely. Joe Roberts for the record, Director of Crisis Response Team. And while that I'm not actually responsible for the Narcan, that falls in line with our CCSD Health Services, we have had fentanyl overdoses in our district. We have employed the Narcan antidotes or antidotants, I guess you would say. That we have those in our schools, in our nurses' health offices, so that they can be deployed if there is an overdose. And so to answer your question, yes, we've had that, and we have mitigating factors in place across our district.
Thank you. Thank you, Madam Chair.
Thank you for the question. Are there other questions from Clark County? I hear someone's mic on, or sorry, from...
That's mine, Madam Chair.
Yes, please go ahead, Dr. Titus.
Thank you. I know everybody's anxious to go to lunch, but I just want to acknowledge the presentation. Director McGill, I appreciate, and the folks from Clark and Washoe County. From what I'm looking in our schedule, it's probably the last thing we're going to actually hear from the schools. And so if I might just kind of circle back to the presentation initially on the trends in school discipline and behaviors. And one of the things that Director McGill mentioned early on is partly some of this attacks and this the violence to students and staff is happening because there's not enough adults in the room. I'm not hearing in any of the presentations engagement with the teachers themselves. From what I'm understanding, teachers are afraid, teachers are retiring, and I'm wondering if at some point we can get a presentation, or if you already have done this, some analysis of why teachers are afraid, why teachers are leaving the classroom, and what resources do the teachers have, because I believe it all ties together. I believe that the teachers will be able to teach better if they feel safe themselves, and students will be able to learn better if they have teachers. And so I'm just wondering, I hadn't heard anything engagement with teachers in this particular presentation, and is that something you're looking into? Is that something you've done? Are you doing surveys when somebody leaves early retirement on why they're retiring? Because again, what I'm hearing, and it is just anecdotally, and I really try to stay away from just anecdotes. I'd rather have actual studies done and true documentation on what their answers are, or why they're leaving, and why we can't fill our classrooms. So is there anything being done along that line?
Christy McGill for the record. We are doing, and so are the districts doing, and we can have that data for you when we start getting it in. We're doing some climate surveys with the teachers, and I know that our districts are doing some surveys as well. So those have not been concluded yet, but we can get that. We did do the well-being survey to some of our teacher population that, again, we can get that data up to you guys.
That would be great.
Great, thank you.
Thank you. And I appreciate the tie-in to workforce and behavioral health services, and even just support services in schools in general. And it's interesting to see how our committees overlap sometimes, and we have these intersectional issues that come up, and where those conversations belong. So we appreciate the follow-up on that when those data come in. Are there any other questions from the committee before we break for lunch? I'm not seeing any. Thank you so much for being here and for presenting on what you're doing in your counties. We look forward to some of those follow-up items from you. With that, I'm going to go ahead and have us break for lunch. We're going to do, hold on a second. We're going to do a quick 30-minute lunch. There should be lunch down there for you guys in Grant Sawyer, and there is lunch up here as well. We will reconvene at 1:15. Please be back in your seats, and if you are virtual with your camera on at 1:15. Thank you all so much.